Welcome everyone to today's roundtable discussion with Dr. Lawrence Afrin. We are Renegade Research. We are a nonprofit, decentralized, patient and caregiver-led organization. And our focus is on post-infectious chronic conditions, especially ME/CFS and long COVID. This would not be possible without the amazing work of our staff and volunteers. And today we have with us Rochelle, we have our founder, Tess Fowler, we have Michael, Ellie, and Nick. Thank you for being here, and I'll pass it on to Ellie to introduce our guests.
Thank you, Isabel. We have a special guest panelist today who could join us. Her name is Dr. Alba Azola, and she is assistant professor at Johns Hopkins, where she led the creation of a comprehensive multidisciplinary clinic for post-acute care of COVID patients. Her clinical and research focuses on long COVID patients that also meet ME/CFS diagnostic criteria. In 2023, she joined the Confounding Clinic at the Children's Center, founded by Dr. Peter Rowe. Now I get to introduce to you Dr. Lawrence Afrin. After training at the Medical University of South Carolina, Dr. Afrin practiced and researched hematology and oncology. Since about 2005, his work has come to focus on mast cell disease. He's done numerous lectures, podcasts, and interviews around the world about this topic. Dr. Afrin has most recently been developing an independent institute located in the greater New York City area for advancing care, research, and education in mast cell disease. His publication record includes some of the most highly accessed articles about MCAS and a popular book called Never Bet Against Occam, Mast Cell Activation Disease, and the Modern Epidemics of Chronic Illness and Medical Complexity. Please take us through MCAS 102-A, the complexity of MCAS diagnosis.
Thank you, Ellie. Let's do the screen sharing here. Okay, just verify again, is everybody seeing the screen okay?
Yeah.
And I just got to figure out how to get this menu bar off of my screen. Won't be good enough there. All right. So thank you, everybody, for tuning in or returning. If you saw the intro lecture a couple weeks ago, fortunately, we're able to do this lecture. This is the longest of the set of 3 lectures. So just to set expectations, this will probably run a good bit closer to an hour and a half rather than the hour that the first and the third lectures typically take. But fortunately, we've got a weekend here to do this, so not quite as constrained for time. So let's get into it here. This lecture will focus on the approach to diagnosing MCAS. The objectives, again, trying to understand the details of the general approach for diagnosing MCAS, understand some of the challenges in diagnosing it, and we'll delve a little bit into the relationship between MCAS and hereditary alpha tryptophanemia. Have no conflicts of interest to disclose. And again, if we do mention any treatments in this talk, they're not FDA. There are no FDA approved treatments yet for MCAS, principally because the FDA, much like most of pharma, don't yet even know that MCAS exists. So by definition, all treatment options discussed are consensus viewpoint or expert opinion. So the outline here, we'll talk about the diagnostic criteria for MCAS and then the general approach to the diagnosis. The diagnostic workup, we'll talk about specific aspects of measuring the various mast cell mediators that typically get checked out in this diagnostic workup. We'll talk about some autoantibody issues in the diagnostic workup, tissue biopsy issues, As I said, a little bit about hereditary alpha tryptophanemia, and also just so that you don't think that every chronically mysteriously ill patient necessarily has MCAS at the root of it. We'll talk a little bit about differential diagnostic considerations, which we actually also covered a little bit of in the first talk about a couple weeks ago. All right, so just a quick review. What is MCAS? It appears to be an extraordinarily heterogeneous, chronic, multi-system polymorbidity of general themes of inflammation. That's the chronic multi-system inflammation. That is the sine qua non, the universal constant of MCAS. Then there's a plus minus on the allergic type issues, and I say plus minus because there are plenty of mast cell patients who don't have a speck of allergy to them, and others, fortunately, quite few of them, who are literally in 24/7 anaphylaxis. And then everybody else with MCAS is kind of somewhere in between those polar opposite ends of the allergy spectrum. And there's one other general theme to this, also a plus minus, because plenty of patients don't have this. But because many of the mast cell mediators are integrally involved in guiding growth and development in all tissues in the body, no surprise if you have chronic inappropriate release of those growth influencing mediators. No surprise you might easily be able to get any of a wide array of aberrancies in growth and development, very commonly cysts and fibrosis, vascular issues, other connective tissue issues, even neurodevelopmental disorders. It's just a huge range of dystrophisms that can result from MCAS. And let's also be clear that MCAS, it's becoming apparent that MCAS is actually the far dominant bulk of the iceberg of mast cell activation disease. There's the tip of the iceberg that is the cancer of the mast cell, mastocytosis in its various forms. And then there are sort of the obvious other mast cell activation diseases, the allergic disorders. But far beyond all of that is kind of all the rest of mast cell activation syndrome. The bulk of the iceberg submerged below this waterline of pretty easy clinical recognizability. And the prevalence estimates for MCAS range anywhere from rare, those are some old estimates by folks who may not have had a whole lot of experience with this, but the more recent research has been fairly consistently demonstrating prevalence figures of somewhere in the 17 to 20% range, at least in the first world Western countries. We think this is a primary disease in most MCAS patients, that it is rooted almost always in various mutations in various genes inside the dysfunctional mast cells, various genes that are of importance in regulating the behavior of the mast cells. And we know from the research these usually are not inherited mutations, or almost always acquired mutations, typically starting pretty early in life. But as a mast cell patient goes through life, from time to time, they can acquire additional mutations in those dysfunctional mast cells. And of course the progenitor stem cell. And this is what then leads the disease to demonstrate its natural lifetime course of a stepwise escalation in the baseline level of misbehavior of the dysfunctional mast cells. So that's what's driving the disease in most patients who have this. But we also know there are a few patients in whom there can be autoimmune drivers of the disease, and possibly even other primary other mechanisms for driving primary mast cell disease. The other possibility in some of these patients is that it's purely a secondary disease. In other words, entirely normal, genetically normal mast cells that are just inflamed, either activated either acutely and or chronically, secondary to some other disease such as malignancy or infection or toxic exposures, whether obvious or not. We know from the presently available preliminary research in this area that MCAS is only rarely identifiable as a clonal disorder at present, but that's because the only tests for mast cell clonality that we have clinically available at this time target specific types of clonality that are pretty much only seen in mastocytosis. There are very few MCAS patients who demonstrate these particular types of clonality. The KIT codon 816 mutations and flow cytometry showing CD117 co-expression on the mast cell surface with CD25 and or CD2. We know from the published preliminary research, most mast cell patients have a huge menagerie of other mutations in KIT and a bevy of other mast cell regulatory genes. But that genetic testing is not presently available in any clinical laboratories right now. So we can't presently identify most cases of MCAS as clonal, even though that's what the research is showing, that most cases of MCAS are clonal. So I just want to make this point because there are some authors in the literature who have been repeatedly asserting for more than a decade now that most cases of MCAS are non-clonal, and they base that on the testing that shows that the KIT codon 816 mutations are negative and the flow cytometry is negative. But that really doesn't even begin to do the extent of testing that's needed to be done to fully probe for clonality. So just be aware of any assertions without good quality proof that most cases of MCAS are non-clonal, because that really does not align with what the research, the published research is showing. Proposed criteria for diagnosing MCAS. There is no true consensus yet, probably no surprise given that it's only been about, let's see, 14 years now since publication of the first set of proposed criteria for diagnosing this extraordinarily variable and heterogeneous disease, this very nebulous disease. There are, at present, there are actually a number of proposals out there, but the two dominant proposals have come to be called the Consensus 1 proposal and the Consensus 2 proposal. To be fair, the Consensus 1 proposal is described by the authors of that proposal not as the Consensus 1 proposal, but rather as just the consensus proposal, because in their from their perspective, you know, if you don't agree with them, you're wrong. It's our way or the highway, and there cannot be any other consensus. So that's why they describe their proposal as the consensus proposal. But there are a number of problems with this proposal. We'll get into a little bit more of that in a few slides here. And I think the key thing to understand is that the way the Consensus 1 criteria are structured, they are much more likely to exclude patients who truly have MCAS, at least MCAS as might be recognizable by the Consensus 2 criteria. The Consensus 2 criteria supported by a different group of investigators and clinicians takes a somewhat broader view of the range of issues the disease can manifest and the range of approaches that are legitimate to diagnosing the disease. It's important to, be able to say with some degree of confidence whether a patient does or does not have a disease, because for many doctors, the diagnosis makes a difference as to whether the doctor is going to seriously consider certain treatments or not. So it's unfortunate when somebody whose symptoms have long been suggestive of MCAS, at least as would be regarded by the consensus two folks, they go to see a doctor, consult a doctor who perhaps is more familiar with the disease from the consensus one angle, and an evaluation it does not show evidence of the disease per the consensus one criteria. The patient gets told they don't have a diagnosis of MCAS. No other diagnostic suggestions are provided, and that leaves the patient adrift once again. And they've typically been adrift for decades by that point. So consensus 2 has been criticized for having the potential to overdiagnose, and that's understandable. But in practice, I really haven't seen that happen. I'll just leave the whole 1 versus 2 argument at that. Here's a slide that basically talks a little more detail about the consensus 1 criteria. Originally published a decade ago, I'm sorry, a dozen years ago, and they said you had to have a multi-system presentation of symptoms that are consistent with chronic inappropriate release of mast cell mediators. And you also had to have an increase in the tryptase level, the serum tryptase level, by at least 20% above an asymptomatic baseline, plus an additional 2 nanograms per milliliter, and you had to have that increased level found within 4 hours after onset of a symptomatic flare of the disease. And you also had to demonstrate at least some response in at least some of the symptoms to mast cell targeting treatment, such as antihistamines. Over time, there's been a little bit of modification of these criteria, principally with regard to the symptoms. Originally, the consensus 1 proposal did regard neuropsychiatric symptoms as potentially, indicative of the disease, but more recently they have deleted consideration of neurologic issues. And more recently, too, they've come to much more strongly emphasize anaphylaxis and saying basically there might be some rare patients who don't anaphylax but could still be legitimately diagnosed with MCAS, but they've been saying fairly consistently for a few years now in their published literature that if you don't have anaphylaxis, you almost certainly don't have MCAS. And that's unfortunate because literature from the consensus 2 cabal has clearly shown that anaphylaxis or anaphylactoid type events are seen in only about 7% of all the patients who come to be diagnosed with MCAS by the consensus 2 criteria. So anaphylaxis, like many other symptoms in it's just another symptom that you might see in some MCAS patients, but plenty of MCAS patients don't anaphylax. They never have, they never will. So it's another point of contention between the two groups. With regard to the increase in the tryptase, it's probably worth pointing out that it's often very difficult for these patients to get any medical attention within 4 hours after onset of a flare, let alone actually have a tryptase level, a fairly esoteric blood test for, say, an urgent care or an emergency room doctor to draw, and they don't want to have responsibility for following up on it when the results come back a week or 2 weeks later. It's also interesting that they require patients to demonstrate this 20% plus 2 increase above an asymptomatic baseline, and yet across the thousands of mast cell patients I've encountered in the last 16 years, I've been falling down this mast cell rabbit hole. I don't think I've ever seen a truly asymptomatic MCAS patient. Yes, many times they are feeling relatively well, but that still is far from truly asymptomatic. So that's another issue. And furthermore, it's interesting to note that this formula of 20% plus 2 being taken as a marker of pathologic activation of the mast cells, there's actually never been any data in support of that formula, any data published whatsoever. The Consensus One group kind of came up with this formula at a closed meeting they had in Vienna a number of years ago, but there's never been any data to demonstrate the validity of this, with the exception, I think there was in the perioperative anaphylaxis setting, there is some validity to this. And there, I believe, was a small study, pediatric presentations to the ER. This is a Brazilian study, if I'm remembering right. And those pediatric patients presenting with a sort of anaphylactoid type presentations, there seemed to be some validity of this. But again, most mast cell patients don't anaphylax. And so in my experience, most mast cell patients have a totally normal tryptase that doesn't even vary by 20%, let alone 20% plus 2, even when they're in the midst of a marked flare of symptoms. Sometimes, curiously, the tryptase level even goes down a little bit when they're in the midst of an acute flare. So just something for you to keep in mind when you see these descriptions of the 20% plus 2 formula. There are some catches to the validity of that. This slide basically talks about all that. And I don't think we need to spend, actually, there is one other item I wanted to talk about here, the last item, that the Consensus One criteria actually require. You have to demonstrate a response to mast cell targeted therapy before you can even be diagnosed with the disease. And obviously, we more commonly diagnose before we treat, but the way these criteria are structured, they require that you treat before you diagnose. This criterion also assumes that all patients with this very heterogeneous disease will respond to the first 1 or 2 interventions you might empirically try, but it's fundamentally an extraordinarily heterogeneous disease, and there can't be any rational expectation that every patient is going to respond to the first 1 or 2 things that a doctor empirically tries when he is at the point of still guessing the diagnosis of MCAS. And there probably aren't too many clinicians who, after they see the patient fail the first one, or many doctors, even after the patient fails the first empiric treatment, they won't even go on to a second. Fairly few clinicians, after seeing a patient fail 2 empiric therapies, will ever go on to try a third. And yet I've seen no end of these patients who it's the third, fourth, fifth treatment you try before you finally start moving the needle, so to speak, on at least some of the symptoms. And this just reflects the extreme heterogeneity of the disease. So this criterion too is another problematic point with the consensus 1 criteria. Consensus 2 criteria are structured kind of akin to how the diagnostic criteria for mastocytosis from the World Health Organization are structured, in that you have a major criterion and several minor criteria to pick from. The only major criterion in the consensus 2 proposal is you basically have to have symptoms of chronic symptoms that can be attributed to pathologically increased uh, uh, release of mast cell mediators. And then you have to have one or more of the minor criteria. And the one that usually gets picked is this fifth one here, which is the laboratory evidence. That's obviously the highest quality evidence of that you really do have a mast cell activation condition present in the patient. And this is the area that we're going to be spending most of our time this afternoon talking about, the laboratory testing. So to actually diagnose this, let's point out, first of all, the obvious. You can't diagnose something until you first at least recognize the possibility that maybe this disease is what's going on in the patient. You know, if you don't put the disease in the differential diagnosis, you'll never make the diagnosis. So this is a real challenge with MCAS, because the traditional diagnostic paradigm, you combine a certain symptom for any particular disease, you put that together with a certain physical exam finding, a particular test result. This is what leads you to suspect a particular diagnosis, but this tends to not work very well for MCAS because, again, of its extreme heterogeneity, not only at the mutational level, but it's that mutational heterogeneity that kind of inescapably drives extreme heterogeneity at the mediator expression level. And that extreme heterogeneity of mediator expression then, of course, is going to drive extreme heterogeneity at the superficial clinical level with the symptoms that are seen, the exam findings that are seen. So it turns out there are patterns that can be recognized here, but you have to sort of back up and look at this from the 100,000-foot perspective, and look and try to recognize one of either of two meta patterns that this disease presents with, either multiple chronic inflammatory ills, often unsatisfactorily responsive to treatment of one sort or another, typically targeted at some superficial diagnosis. Or maybe the patient has had a very definitive diagnosis established, say a lymphoma, but that doesn't come anywhere close to explaining all of the symptoms and findings and test results in the patient, telling you that something else is going on here and you need to keep looking further. Not to say the original diagnosis is invalid or should not be treated. It's just that there's something else going on that may be independent from the definitive diagnosis or might actually underlie and be further stoking the more superficial diagnosis. There are some validated screening tools available. There's, for example, a checklist put out by the researchers at the University of Bonn. Gerrit Molderings and colleagues put this out originally, actually almost 20 years ago at this point. So this is readily available, been published in a number of open access articles in the literature, and this can be used for screening purposes if you want. But by and large, this comes down to clinical recognition of who likely has MCAS, and then, how do you go about proving it? So the general approach to diagnosing MCAS, the hardest part of this, without question, is taking the time to appreciate the full range of problems in the patient. And this very much goes against everything we physicians have been taught in our training. We've been taught to focus from the very beginning of the encounter in a chief complaint, and we might peripherally take a few other points of history, check a few other things on exam. But by and large, everything is focused on a chief complaint, and that approach is just not going to win the day in dealing with MCAS. You've got to take and retake a full history, take a full review of systems like you first learned how to do in your medical training, and you got to perform a full physical exam. These mast cells are everywhere in the body. They easily have potential to interact with every tissue, every organ, every system in the body. Doesn't mean they will interact with every system in the body, but there's certainly potential to it. And unless you do a complete job here, you're not going to understand but a small fraction of what this disease has been doing in the patient. So you just got to take time. Take a lifelong history. The symptoms of MCAS usually date back at least to adolescence. Not uncommonly childhood or even infancy. The symptoms are often chronic and recurrent, many times episodic or intermittent, with the acute flares of symptoms, and or waxing and waning. The flares may happen at any time, but often are in reaction to some exposure or an event, and it many times can be devilishly difficult identifying what that exposure or event actually was. I'll be the first to acknowledge this is not easy. The flares are usually temporary, lasting anywhere from a few minutes to at most a few weeks or months, but occasionally are permanent. And in that case, of course, they're not really flares, but they're more escalations in this natural lifetime course of the disease that I described before. So again, retake a lifelong history, block out the time needed to take a long history. This is not a chief complaint directed history. These patients typically have a zillion complaints. It frustrates everybody, and you'll be less frustrated if you just set appropriate expectations for yourself right from the beginning of an encounter with one of these patients. And because the symptoms are all over the place, they intersect with so many different systems in the body, taking a systems-oriented history often is little more productive than taking a chief complaint-directed history. I've learned everything about this disease that I've come to know. I've learned it the hard way, but if you really want to understand what this disease has been doing to the patient, how they got to their present state, you really got to take this in a chronological fashion. And it's hard for somebody to chronologically reconstruct their life. So don't be surprised if, they're, 3/4 of the way through their life history, and then suddenly they're remembering things back from childhood that they forgot to tell before because they had long ago just suppressed the memories because they learned nobody would ever pay attention to those symptoms. And they learned if they kept complaining about those symptoms, it would actually be counterproductive because the doctors would just keep running the same tests that had already been run 10 times, finding no answers and just telling them it was all in their head. So these patients learn to shut up and not reveal their complaints. They accept their unwellness as their normal, and they stop complaining about many of all but the worst of their symptoms. So you often have to extract out of these patients various elements of history they had long ago stopped talking about. Keep in mind too that stress can escalate often permanently. Again, this escalation behavior. The base of stress, either physical or psychological, can escalate the baseline misbehavior of dysfunctional mast cells. And we all suffer stressors at various times, and so the social history is important. There often are escalations with this disease at puberty, menarche, going off to college, marriage, first intercourse, pregnancies, deliveries. Can't deny those are physically and psychologically stressful events. Major employment, issues, major family stressors, relocations, can be psychologically stressful, but also can be quite physically stressful and can also expose the patient to a whole new set of environmental antigens they had never been exposed to before, and that sometimes too can be problematic. Physical stressors which can escalate MCAS include surgery, trauma, puberty, major infections, sometimes even vaccinations. I am not saying MCAS patients should not get vaccinated. Vaccines obviously are incredibly important personal and public health tools. What I'm saying is when a mast cell patient gets vaccinated, has a significant adverse reaction to it, it's almost certainly because their dysfunctional mast cells have not been recognized yet to be present, and there's no diagnosis, there's no treatment, they're uncontrolled. But once you bring an MCAS patient's mast cells under a halfway decent level of control, then they tolerate pretty much any vaccination pretty much as well as anybody who doesn't have MCAS. But nevertheless, we do have to recognize that vaccinations can be major. They're kind of designed to be major immunologic events. Novel antigenic exposures can be major physical stressors. And also note that when the medical problems fairly suddenly, significantly worsen, you got to search for what's changed recently, what stressors did they recently suffer, what new exposures did they suffer in the few days to at most a few months prior to the exacerbation. The vast majority of the time, it's within just the last few days that's the new exposure that's driving a sudden worsening of the disease. Quite often, it's just going to the pharmacy and getting a refill, but the pharmacist switches them from one medication formulation, one formulation of a given medication to another formulation. Might even look identical, but the excipient, the inactive ingredients have changed from one manufacturer to another. And if the new product has an excipient that is a trigger for the patient's dysfunctional mast cells, then they're going to appear to start having a flare of the disease, even though they're just continuing to take their regular medications. So again, take and retake a lifelong history, take a full review of systems. And again, most MCAS patients learn early that complaining about their symptoms was unproductive, even counterproductive, both diagnostically and therapeutically. Sometimes the doctors ask them to try various treatments just as an empiric effort to try to address various symptoms. And some of these treatments can be quite expensive. And they're probably not going to help if you don't have the right diagnosis. So they stop volunteering their symptoms, ask them about their symptoms, and they come to accept them as normal. They come to live with them. So this slide and the next slide are most of the areas I have learned to cover in going through the review of systems with one of my patients. Yes, it's kind of getting back to basic roots in medical school, but this is what you have to do in these patients. I'm not going to go through these items. I think these slides are being made available to the audience, so you can go back and review these two slides later at your convenience. But you can get a general sense from a glance at these slides as to how broad an array of issues you do need to specifically probe into with these patients. And that's the last of the 3 slides on the review of systems. And you need to perform a full physical exam. There's no tissue which is immune to potentially being affected by the disease. These cells reside in essentially every tissue in the body, but are greatest numbers at the environmental interfaces. So the integument, the respiratory tract, the GI tract from stem to stern, and the genitourinary tract. And so they're at the environmental interfaces and directly abutting all vessels and all neurons. This is where they're dominantly sited. So you do a complete physical exam, as noted here in the last bullet point, and you very likely are going to find at least some signs of the disease. For example, there may be some hints in the vital signs. For example, lability in pulse. These patients very commonly demonstrate dermatographism, and there can be a variety of other issues that are seen in the physical exam as well. So the hardest part of diagnosing this, taking the time to appreciate the full range of problems in the patient. The second hardest part, just accepting that there really is a disease that you weren't taught in your training, but which really can account for most of all that's been going on in the patient. Also accepting the high prevalence of this disorder when in training, the only thing you were taught about mast cell disease is this one disease, mastocytosis, that's incredibly rare. And now we have to get past that and understand, no, there's this other mast cell disease that is the polar opposite to mastocytosis in its prevalence. I long ago lost count of the number of docs who have come up to me after coming to recognize MCAS in their first 1, 2, 3 patients, and they tell me, oh my goodness, now I can see it. I've been seeing these patients left and right all day long, every day of my whole career. I just couldn't previously recognize them for what they are because nobody ever taught me such a disease exists. And the other confounder is that the biological complexity of the disease is so great that they inescapably present at the superficial clinical level so differently from one affected patient to the next to the next. And this is not how we were taught to diagnose. Diagnosis is an art and pattern recognition. Most diseases present in, 1 or 2 ways, and that's it. But this disease can present in 100, 1,000 different ways. And yes, there are these meta patterns that can help you recognize the likelihood of MCAS being present here. But at the superficial clinical level, and given the particular manners in which we've all been trained to diagnose, it can be hard to learn how to recognize this. The third hardest part in diagnosing this is not rushing to a diagnosis of MCAS. There are some other diseases that can drive a lot of the symptoms you can see in MCAS, so you got to think about whether other diagnostic considerations are worthwhile. And pursue other workups as appropriate. The least difficult part, I'm not saying it's easy, but the least difficult part in diagnosing this is finding the laboratory evidence of it. And let's talk about that. So first of all, I would encourage anybody looking to diagnose this to strongly consider seeking at least 2 points of laboratory evidence. Any test could yield an abnormal result once by chance or error. This is a life-changing diagnosis, usually not a life-shortening diagnosis, but nevertheless, the diagnosis puts these patients on a therapeutic path for the rest of their lives that they would never be on if they didn't have this diagnosis. So I consider it to be a life-changing diagnosis, not only for the patient, but their implications for decades to come for the families too. So it's an important diagnosis, and we probably shouldn't be making a diagnosis as important as this one based on finding just a single piece of laboratory evidence, given that any test could be abnormal once by chance or error. So the most common types of laboratory evidence are either elevated levels of mediators relatively specific to the mast cell. These cells are putting out more than 1,200 different mediators, most of which we can't even measure in the clinical laboratory. But of the minority we can measure in the clinical laboratory, most of those are not particularly specific to the mast cell. So yeah, you can run an interleukin-6 level in blood and urine, and if it's elevated, yeah, they've got a strong inflammatory state in them. And yes, the mast cell does put out a lot of IL-6, but so too do a lot of other cells. So out of more than 1,200 mediators these cells produce and release, there are only roughly 10 that we can test for in the clinical laboratory at present, and which are fairly specific to the mast cell. So just keep in mind that if you're trying to figure out how could it be that a mast cell patient where you ran the diagnostic workup and you got a couple of mildly elevated histamine levels, and yet they're so screamingly symptomatic, how could that histamine, those mildly elevated histamine levels, be causing all those bad symptoms? And the answer is they're probably not. It's probably mediators other than the few we're measuring. That's what's driving most of their symptoms. It's just that at present, these 10 or so, this is all we can measure that's specific to the mast cell. So this is what we do. But don't forget for a moment that what we're measuring here is a terribly poor surrogate for the totality of the signaling, the massive signaling chaos that's going on in this disease. So we look for either one particular mediator elevated repeatedly or different mediators elevated at the same or different times. That's the highest quality of evidence. It's not called a mast cell activation syndrome for nothing, and activation is definitively shown by finding elevated levels of the mediators that are specific to the mast cell. The consensus 2 criteria do also allow for finding increased numbers of mast cells in various biopsies. The consensus 1 criteria do not allow that. The consensus 1 literature has repeatedly stated there is no number of mast cells you could ever find in any tissue, as long as it's not looking like the classic appearance of mastocytosis. But south of that, there's no number of mast cells you could find in any tissue that would ever be considered to be abnormal. And that's what they've been repeatedly publishing for a long time now. And there are obviously many things about that that just don't make a whole lot of sense. And so with the consensus, and just another reason I tend to side with the consensus 2 criteria, that finding increased numbers of mast cells in tissues is another way to diagnose it. But keep in mind that the pathologist actually cannot see anything under the microscope that'll tell them what the activation state of the mast cell is. So we infer from increased numbers of mast cells in the biopsies that there's probably also increased activation, but it's not as definitive a piece of evidence as actually finding an elevated level in the blood or the urine of some mediator that's fairly specific to the mast cell. But the consensus 2 criteria allow for looking at the biopsies because we recognize there's a lot of places in the world where you literally don't have access to the mediator testing. And all you can do is endoscopies and biopsies. So the mediator testing, we'll talk about that for a good bit here. I'll be the first to acknowledge this is quite challenging. Many of these mediators are highly thermolabile, have very short half-lives. Most of this testing is send out, increasing the links in the chain of handling and thus the potential for mishandling of the specimens. There are a number of medications that have potential to confound some of the mediator tests. So if possible, you want to have these patients off non-steroidal anti-inflammatories, and that includes salicylates and other anti-inflammatory supplements for about a week in advance of collecting the specimens. It's not always possible to have patients off these drugs in advance of testing, so you just do the best you can. So they want to be off the anti-inflammatories, the NSAID, the COX-1 and 2 inhibiting anti-inflammatories. Acetaminophen doesn't work that way, so that's okay. But because some of the mediators we look at are prostaglandins, and because COX-1 and 2 inhibitors are going to interfere with prostaglandin production, that's why we want these patients off COX-1 and 2 inhibitors for a week or so in advance of testing if possible. And many of the anti-inflammatory herbs and supplements that are out there actually are anti-inflammatory because they are COX-2 and or COX-1 inhibitors. We also measure leukotriene E4 in this testing. So the leukotriene receptor blockers are not problematic. The same way histamine receptor blockers are not problematic. That's not going to interfere at all with the actual level of histamine that's floating around in you. But any leukotriene synthesis inhibitors, which are pretty rarely used, they need to be avoided. There are a very few drugs out there that can also interfere with histamine production, and they're pretty rarely used. We want to have patients off those drugs as well. But the receptor blockers are not known to be problems. Cromolyn not known to be a problem. Benzodiazepines and cannabinoids that can be helpful in mast cell disease are not known to be confounders of the testing. That all having been said, let's be honest, we are only 17 years since the publication of the first case reports of this disease. Overall, relatively little research has been done in this disease, and it's always possible that at some point down the road, somebody will do some new research and show that, oh yeah, one or another of these drugs that are commonly used to treat this disease really can interfere with one or another of these mediator tests, and then we'll have to revise testing guidance at that time. But for right now, this is the best we know. Mediator testing not uncommonly yields negative results even in spite of flagrant symptoms. Again, keep in mind you're testing only a terribly poor surrogate for the totality of the signaling chaos out there. And the testing is very technically challenging. So if you get a negative result, it's not surprising. Review the circumstances, ask the patient if they kept the 24-hour urine sample chilled throughout collection and transport to the laboratory. Ask them if they witnessed the laboratory technician keeping the random urine chilled, keeping the blood specimens chilled. You debug ask them if they accidentally took any of the interfering medications. I'm sorry, I forgot to mention regarding interfering medications that supplements of vitamin C, D, and E actually can interfere with some of these tests, and you have to be off them if possible for a week in advance. And the proton pump inhibitors can artifactually elevate chromogranin A levels, and you got to be off those drugs for 3 weeks if possible in advance of testing. So anyway, back to trying to debug. If you get negative results, you do the best you can and try to debug why you might have gotten negative results. Sometimes you have to debug a positive result if you get an elevated chromogranin A. Even though they originally told you they weren't using a proton pump inhibitor, and you got to go back and ask them, did you use a proton pump inhibitor? Between the time we first talked and the time you actually turned in the specimens for the testing, because many patients even if you explicitly discuss this with them at the initial consultation, they're still not going to have it straight in their head exactly what a proton pump inhibitor is. And many of these drugs are over the counter, and many of these patients have GI troubles. So they're having troubles in a day or two before they're going to submit for testing, and they go to the drugstore in the middle of the night and they grab a drug off the shelf in the stomach upset aisle, and they take it, and they've accidentally taken a proton pump inhibitor. Possibly. So these are the things I've learned over time. You have to go through with these patients when you get back results that you're not quite sure whether they're valid positives or valid negatives. I've also learned across thousands of patients that the vast majority of patients who behave like they have MCAS indeed have detectable elevations in at least one of the commonly tested mediators within 3 rounds of properly handled non-invasive testing, blood and urine testing. If the testing isn't even handled properly, if the patient witnessed the phlebotomist or the lab technicians not keeping the specimens continuously chilled, then it's really not a negative round of testing. It's an uninterpretable round of testing, and it's regrettable. It's the waste that it was, but it's not a negative round of testing. There's great thermolability with many of these mast cell mediators. Heparin has a half-life at room temperature or higher of about 30 to 60 seconds. Prostaglandin D2 and histamine about a minute. 2,3-dinor, 11-beta prostaglandin F2 alpha, which is the principal immediate metabolic breakdown product from prostaglandin D2. That's also got an equally short half-life. And methylhistamine, which is the principal immediate metabolic breakdown product of histamine. Once histamine gets filtered by the kidneys out of the blood and dumped into the urine, N-methylhistamine fortunately has a somewhat longer half-life. Tryptase in vivo, short half-life, but once you separate the serum, has a longer half-life. I've learned that the continuous chilling is just essential. And this is a small paper I published a number of years ago demonstrating this, where we had a period, I was working at an academic medical center. I had started working there. I had explained to the technicians in the lab how these samples had to be handled. And for the first, a bit of time there, they just weren't paying attention to the instructions I had given them. And so we kept getting back heparin levels of 0, 0, 0, 0, 0, in spite of symptoms in all these patients that were just screaming MCAS, and heparin ought to be elevated in a significant fraction of these patients if the samples are handled properly. So finally, we figured out that the issue was with the technician, and she wasn't paying attention to the instructions. And once we got that sorted out, the next day we started getting positive heparin levels. And then a little bit down the road, the levels fell off to 0 again, went back and checked again, and found that another technician had come in to work in that position, and she was once again ignoring the instructions. And once we got that fixed, then we started getting positive levels again. So the chilling really does matter with maybe not every mediator, but nevertheless many of them. Plan B, if for getting laboratory evidence supporting the diagnosis, if 2 to 3 rounds of properly handled blood and urine testing doesn't get you anywhere, despite the history and physical being suggestive of MCAS, is you pursue the tissue biopsies, almost always GI. Endoscopic GI tract biopsies, but sometimes there's opportunity to get genitourinary tract biopsies. The vast majority of the time, you don't even have to get new endoscopies and new biopsies. These patients have been so sick in the GI plus minus GU tracts for so many years, they've already had one or more endoscopies done, one or more biopsies obtained, and thank goodness. I mean, you can't go back to old blood and urine specimens to retest them for evidence of mast cell disease. They have no shelf life. Those specimens get thrown away almost immediately. But thank goodness the pathologists hang on to the old biopsies for about 10 to 20 years. And you can go back to the old biopsies and get them restained in the special fashions needed to identify the mast cells in the specimens. So my own approach is that even if I find increased mast cells in one or more biopsies, I still like to find at least one elevated mediator level to most definitively demonstrate the actual activation. It's not called an activation syndrome for nothing. All the symptoms are coming from the activation, not coming from an increased number of mast cells, but coming from the activation. And if you're in a place in the world where the mediator testing is readily available, then you really ought to, in my opinion, you really ought to strive for finding at least one elevated mediator level to complement positive biopsy findings. And if you don't have any biopsy findings, then you probably ought to be finding at least two elevated mediator levels. So this is the typical panel I order, CBC. Not that the CBC is going to show me anything specific about mast cell disease, but you're trying to assess the broadest range of systems in the patient's body that are being impacted by the disease, and that includes the bone marrow. Fortunately, you don't have to do a marrow biopsy to understand most of what's happening in the marrow. You can just look at the blood counts peripherally to understand most of what's happening in the marrow. Similarly, with a comprehensive metabolic panel looking at how the liver and the kidneys are functioning, very occasionally you'll find a variant of MCAS that is manifesting severe hypomagnesemia. So you just have to be sure magnesium has been checked at some point. These patients very commonly have easy bleeding and bruising, probably because their dysfunctional mast cells are inappropriately releasing heparin and other anticoagulant mediators. But there can be a whole range of ways this disease intersects with the coagulation system. So check a PT, INR, and PTT. And if there are significant abnormalities, consider looking for antiphospholipid antibodies or testing for other coagulopathies as appropriate to the clinical situation. I also check, in addition to those general tests, looking at the hematologic, coag, and liver and kidney systems. I then look at these mediators. I check a chilled serum tryptase and chromogranin A, chilled plasma prostaglandin D2 and histamine and heparin, chilled random and 24-hour urinary prostaglandin D2, 2,3-dinor 11-beta prostaglandin F2 alpha, N-methylhistamine and leukotriene E4. And a couple of autoantibodies that need to be looked at as well, anti-IgE antibodies, and that's different from the IgE class of antibodies. So don't go thinking that getting a quantitative IgE level is what we're talking about here, because it's not. We're talking about anti-IgE antibodies as well as anti-IgE receptor antibodies, and that can be a tricky one because that test is known by a lot of other synonyms as listed here. Tryptase, highly but not perfectly specific to the mast cells. It's a large part, 20-25% of all the protein made by the mast cells. To this day, we still have no clear idea what its principal function in human biology is. We've identified a number of its functions, but it's still not clear what its principal function is. It's got very complex biology with many isoforms. It was actually described, I can show you the article from the New England Journal in 1987, trumpeting in the title of the article that tryptase is a marker of mast cell activation and mastocytosis. But fast forward 20 years and we began understanding, no, actually, tryptase is a pretty miserable marker of activation of the mast cells. Instead, what's happening is all mast cells are constitutively releasing some amount of tryptase at a baseline level. So the more mast cells you have in your body, the higher your serum tryptase level is going to be. So if you have a malignancy of mast cells, you're pretty reliably going to have a very strongly elevated tryptase level. But if you have a disorder of inappropriate activation of the mast cells with relatively little to no abnormal proliferation of the mast cells, in other words, if you have MCAS, then you should expect the tryptase level to be elevated little to none, usually none. And that indeed is what we see in MCAS. It does have some degree of thermolability to it. It does have a longer half-life in separated serum, but it's hard to know how quickly serum is actually going to be separated. And so I just play it conservatively, and I ask for the tryptase, the tube of blood that they're going to use for the determining the tryptase level. I just ask for that to be continuously chilled along with all the other tubes that are being drawn for mast cell mediator levels. It just makes it easier on the technician. There's this condition of familial hypertryptasemia, also known as hereditary alpha tryptasemia or HAT, that has been newly described in the last few years, appears to be autosomal dominant. It comes down to having one or more extra copies of the TPSAB1 gene for making the alpha chain of tryptase. We know at this point it's in 6% of the general population. The phenotype is highly variable. And many of these patients actually do have mast cell activation phenomena, but it's not clear if this typically only slightly elevated tryptase level that's driven by this genetic condition is actually contributing to the phenotype, or maybe it's just a red herring, and it's actually the other mutations in the mast cells that we can't presently demonstrate in the clinical laboratory. That's what's actually driving the mast cell misbehavior that produces the phenotype in these patients. Enough said on that. All right, so actually, let me back up a second here. So the point I want to make is if you do find a mildly elevated, if you find a strongly elevated tryptase level in one of these patients, if it's persistently double the upper limit of normal or higher, you got to wonder about mastocytosis. So you go doing the testing for mastocytosis, usually bone marrow biopsies. But if it's not, but if you get a mildly elevated tryptase level, you then have to figure out whether the patient has HAT or not. Because if they don't have HAT, then that mildly elevated tryptase level can be counted, so to speak, as a marker of mast cell activation. But if they do have HAT, and that's going to be most of these situations of a mildly elevated tryptase level, if they do have HAT, then all of those tryptase elevations, those mild tryptase elevations, they're consequential to the HAT, the constitutive, the genetically programmed overexpression of tryptase, and it doesn't have anything to do with mast cell activation. So you can't count those elevated tryptase levels in those patients. You can't count those elevated tryptase levels toward a diagnosis of MCAS. There is one laboratory in the US that's currently running this genetic testing for HAT, and I'll get there in a few more slides here. Chromogranin A does have thermostability, but it's just easier on the technician if they handle the tube for chromogranin the way they handle all the other tubes. So I just ask for that to be chilled too. Chilling is not going to hurt the accuracy of a chromogranin A determination. You have to be a little careful in interpreting elevated levels of chromogranin A. There are a few other confounders: heart failure, renal failure, liver failure. proton pump inhibitor use in the last 3 weeks or so, and obviously pretty rarely any neuroendocrine tumors that just naturally produce chromogranin A. Got to watch out for that. But when you have a chromogranin A producing net, they usually are producing chromogranin A at far higher levels than you would see MCAS produce. So again, it's just a matter of learning the patterns here. Chromogranin A is normal in about 2/3 of MCAS patients, but in the other third, it's usually elevated no more than 10 times the upper limit of normal. Prostaglandin D2, fairly specific to mast cell activation. About a dozen other types of cells besides the mast cells make it, but the mast cell makes far more prostaglandin D2 than any of these other types of cells. So if you find an elevated level of PGD2, it's virtually certain it's coming from activated mast cells rather than those other cells. It's quite thermolabile, and there are fairly few labs in the country that are handling it. Up until really just a few months ago, there was only one lab in the country that was running PGD2 testing, InterScience Institute in Southern California outside of Los Angeles. But more recently, some of the major commercial laboratories like LabCorp and Quest have come to run this as well. So that's making it a little bit more accessible. Obviously, anything impeding prostaglandin production can be a confounder, principally the COX-1 and COX-2 inhibitors. Plasma histamine, no clear advantage to plasma versus serum versus whole blood. But a whole blood histamine level may not reflect histamine that's been released from the cells. So I tend to check both plasma histamine and whole blood histamine in this diagnostic workup. Slightly less specific for mast cell activation than tryptase. There's a little bit more histamine release than tryptase release from basophils, but still, it's still a fairly good test for MCAS. It's got a short half-life in vivo, a little bit more stable once the plasma has been separated. But again, it's just easier on the technician to have her handle all the blood tubes for these mediator tests in the same fashion. So I just ask for continuous chilling. Heparin is probably the single most sensitive and specific marker of mast cell activation according to the published literature, but it's also the most difficult mediator to accurately measure because of its extreme thermolability. So you do, and furthermore, most of the heparin assays around in clinical laboratories around the world, they're going to have lower limits of detection of at best 0.10 anti-factor 10A units per milliliter. But the upper limit of normal for the amount of heparin that's being normally released by normal mast cells in a healthy person has been published somewhere in the 0.02 to 0.05 range. So if you use a standard heparin assay, you're probably not going to be able to pick up the more modest elevations in heparin that are more commonly detected. It's pretty hard to pick up a strongly elevated heparin level because, again, of the severe thermolability of heparin. If you do manage to pick up any elevation in heparin at all on a more sensitive, one of these ultra-sensitive assays that are available in some commercial laboratories around the country, if you do manage to pick up some elevation in heparin, it's almost certain that the true heparin level at the time the specimen came out of the patient's bloodstream was probably much higher than what was measured. It's just, you got all these challenges in accurately measuring what's in there. You do the best you can. Urinary prostaglandin D2, I check in the random sample and the 24-hour sample. I got to keep both samples continuously chilled. I actually give them a pre-chilled cup for collecting the random urine and a bucket or a bag of ice to take into the bathroom. So they pee into the cup and it goes immediately into the ice. And my staff in my office are well trained to keep these specimens continuously chilled. You know, when they submit the 24-hour urine specimen at some commercial lab, if they see the technician just take the jug out of the cooler and leave it sitting on the desktop there, and then the patient walks away, you know, walks out of the lab 5-10 minutes later, and it's still sitting there. You know, every minute that's passing by, you're losing 50% of the prostaglandin D2 that was in there at the beginning of that minute. It just has to be kept chilled. Same with the 2,3-dinor 11-beta prostaglandin F2 alpha, which is the principal immediate metabolic breakdown product from both prostaglandin D2 and prostaglandin E2. So not perfectly specific to the mast cell, but PGE2 is not known to be made by mast cells. So 11-beta is accepted as a marker of mast cell activation. Plasma prostaglandin F2 alpha is not known to be specific to mast cell disease, and there's some limited data from laboratories outside the US showing that PGDM, another prostaglandin D metabolite, may also be a useful mast cell activation marker. N-methylhistamine is the principal immediate metabolite of histamine, got a little bit longer half-life than histamine. Normal, we got to be aware the normal range of NMH actually varies in accordance with age. You know, chilled urine, chilled centrifugation, that is better than unchilled. Leukotriene E4 got a half-life of about 7 minutes. It is regarded as a valid marker of mast cell activation, though it's produced in small amounts by some other types of immune cells. Probably best to keep it chilled given the relatively short half-life. Many times I see these patients having their prostaglandin E2 level measured. Mast cells do express receptors for prostaglandin E2, but they're not known to actually produce prostaglandin E2. So measuring a PGE2 level is not going to be a marker of mast cell activation. Sometimes I get asked, does the 24-hour urine collection jug or the random urine cup, does it have to have preservative in it? I know some laboratory reference websites state that preservatives of various sorts can be used in place of chilling, but I've been looking for this literature for more than a dozen years now. I can't find a single publication that shows that there's any preservative of any type that actually keeps these highly thermolabile mediators stable at room temperature. So until I see such a paper, I'm just going to keep chilling. I mean, sure, room temperature would be a whole lot more convenient. You know, just using a preservative would be way more convenient, but haven't found a paper yet that clearly demonstrates that. Again, what are we measuring here? Obviously, we're measuring just a few of the more than 1,200 mediators these cells put out. So we're just measuring a poor surrogate for the totality of the signaling chaos in this disease. And just keep aware that the symptoms they're having probably are not coming very much, if at all, from the elevated mediators, usually pretty modestly elevated mediator levels that you're actually finding in this testing. Antibody issues. Anti-IgE antibodies and anti-IgE receptor antibodies do have some potential to activate mast cells because there are IgE receptors on the surface of the mast cell, and IgE antibodies bind to those receptors. And so if you have other antibodies that either bind to the receptor in an activating fashion, or they bind to IgE that has pre-bound to an IgE receptor on a mast cell, then that can wind up activating the mast cell. But we also have to keep in mind MCAS interacts potentially with every system in the body, including the immune system. And it's very common for mast cell disease to drive the humoral immune system into this wicked sort of inflammatory overdrive where it's producing all sorts of antibodies that the immune system has no legitimate business producing. And these generally are totally randomly produced antibodies. And if you produce enough randomly produced antibodies, some of them just by chance are going to come to resemble in the three-dimensional structure of their FAB fragment, resemble the real antibodies you would really get in a real infectious or autoimmune disease. So it's very common in MCAS to get positive readings on a blizzard of different antibody probing tests, whether probing for infectious disease antibodies or autoantibodies. But the patterns over time and the levels of these mimicking antibodies often are quite different from the patterns over time with the real antibodies. So use your clinical judgment. If you're seeing seemingly positive antibody test results, but the associated infectious or autoimmune disease doesn't appear to be present, then follow your clinical gut. And this is another slide just saying all over again what I just said. And this is another slide saying the same thing. Again, you can go back to these slides to review them. This is a demonstration. The squiggly line in the middle, this is the pattern you see with, true on-target antibodies. When you have a true infection, a true autoimmune disease, this is what the antibody level is typically doing. But if you see line A here, where occasionally you have a slightly positive antibody level and then you recheck it and it drops to normal, and then a little bit later it's slightly positive again, it's bouncing up and down like that, and you just don't see any signs in the patient of the classically associated disease, then no, it's a mimicking antibody and has no clinical significance. And this line A is about 90% of all mimicking antibodies. Line B is about 10% of them, where the level of the mimicking antibody that's expressed is literally off the charts. It's off the scale. And yet you look at the patient and say, where is the associated disease? If this antibody is a real on-target antibody, they ought to have this disease in an extremely severe fashion, and yet you don't see it. And that tells you, again, this is almost certainly a mimicking antibody. So again, another slide here that just says, be careful about how you interpret positive antibody results of any sort in an MCAS patient. In the interest of time, I'm going to go on. Again, trust your clinical gut intuition in interpreting antibody-based testing. If you really want to tell whether a mast cell patient has a given infection or not, you either got to go get a positive culture, and that can be difficult for some of these bugs, or you got to go probing for the DNA the DNA sequences that are specific to that are unique to the genes that are unique to each and every different microorganism. So for some microorganisms, you use PCR. For others, turns out FISH is a better technology. We don't have time today to get into all those details, but you got to go looking for the DNA or the positive cultures if you really want to prove in a mast cell patient that a given infection is truly actively present. Biopsies with cutaneous mastocytosis, the most common form of that disease is urticaria pigmentosa. TMEP is pretty uncommon. These patients, MCAS patients, very commonly have rashes, a waxing, waning, migrating, patchy macular erythema. But biopsies of those rashes usually are not going to be helpful. You get this reading from the dermatopathologist, urticarial reaction or superficial and or deep lymphocytic or lymphohistiocytic infiltration with occasional admixed eosinophils. I've seen that phrasing over and over and over and over and over again. And it's just telling you there's inflammation there and they can't otherwise classify it. It's obviously inflammation that's being driven by the mast cell mediators in some fashion, but you usually don't actually find increased numbers of mast cells in those rashes. So if you don't see a rash that's classic for urticaria pigmentosa or TMET, probably not much point in biopsying it. Marrow biopsies, I'm going, in the interest of time, I'm going to summarize all of this. You can go back and read the details, but I'm going to summarize and say that marrow biopsies are very seldom helpful in MCAS. So unless the patient is clinically presenting in a fashion strongly suggestive of mastocytosis, where they have a persistently strongly elevated tryptase level, and it is a middle-aged or older person who is pretty healthy their whole life up until suddenly getting sick with mast cell activation type symptoms in middle or older age. That's the archetype of mastocytosis. Sure, you need to go doing the biopsies to look for mastocytosis in one of those patients. Otherwise, the yield in doing marrow biopsies in diagnosing MCAS is very low. And after I marrowed my first 100 or so MCAS patient and found evidence of MCAS, molecular level evidence in, I think, a couple of them, I gave up doing marrow biopsies on a routine basis in these patients. If you do the molecular level testing, the appropriate PCR testing and flow cytometry testing, you may find evidence of monoclonal MCAS or MMCAS in 1 to 2% of these patients. But there's no difference that is presently known in either prognosis or approach to treatment between MCAS that has not been proven to be monoclonal versus MCAS that has been proven to be monoclonal. So if there's no difference in prognosis or treatment, why bother going to the effort and any discomfort to the patient in looking for these rare patients who have a presently demonstrable monoclonality in their MCAS? Later on down the road, when the genetic testing gets more sophisticated, we can go probing for these other mutations in KIT and these other mast cell regulatory genes. And then we can go showing that almost every one of these patients are monoclonal, like the research has already shown. Fine, then we should routinely go looking for that monoclonality, because when we understand the mutations that are in the given patient, we'll probably start to better understand how the different types of MCAS patients should be better treated, different treatments for different mutations. But we're a long way away from that point yet. And again, in the interest of time, I'm going to leave all this other marrow stuff for you to read through. And the GI tract biopsy is just a reminder, the pathologist cannot recognize the mast cells for what they are with routine H&E staining. They look like lymphocytes or plasma cells or macrophages or histiocytes or spindle cells. You can't recognize them as mast cells. There's some older, cheaper stains that go targeting the mediators, like a tryptase stain. But think about this, the disease is mast cell activation syndrome. These cells are chronically activated, chronically degranulated. So any stains that are targeting the granules or the mediators within the granules, not going to be all that helpful. You need to use a stain that's targeting something that's always present on the mast cell, whether it's quiescent and fully granulated, or it is activated and degranulated. And that thing that is always present there on virtually every mast cell is CD117 at levels that are tenfold brighter in the mast cell than you see in any other type of cell in the human body, except the interstitial cells of Cajal, the gastrointestinal pacemaker cells. And they have a morphology that's completely different from the mast cell. So even though they will also light up very brightly with 117, you can't mistake them for a mast cell. Just a demonstration of how the CD117 can light up these mast cells, when with H&E, there's no way you could pick them out from the surrounding crowd of lymphocytes, etc. A lot of points here, but in the interest of time, I just want to say that it's easily possible you could find increased mast cells in any segment of the GI tract. The esophagus is typically where we see the fewest numbers of mast cells. The terminal ileum is where we see the greatest number. The duodenum is where we see the second greatest number of mast cells. But you could easily find increased numbers, more than 20 per high power field, in any other GI tract segment as well. So I just asked the gastroenterologist to do a systematic set of biopsies from the upper and lower intestinal tracts, have the pathologist do a 117 staining on each biopsy, and to provide a count of the maximum number of bright CD117 stained cells seen in any one high power field under the microscope for each of these biopsies. High power is 40x, multiplied by a 10x ocular is 400x total magnification. If you get really high counts, you wouldn't be unreasonable in asking for a KIT codon 816V, codon 816 mutation analysis by PCR, but still it's unlikely you're going to find mastocytosis unless it's just grossly looking under the microscope, like the pathologist has been trained to that mastocytosis looks like. Mastocytosis most commonly presents with more than 200 mast cells per high power field. When we see an increased number of mast cells in MCAS, it's usually somewhere in the 20 to 60, maybe 80 or 100 range, almost always less than 50. And in mastocytosis, the mast cells have an abnormal morphology. They're almost always aggregated. You don't see that in MCAS. They're almost always spindled. You don't see that in MCAS. And we talked here about why 117 is better than the other stains. And I'll be the first to acknowledge that our present upper limit of normal of 20, there are a lot of issues with that. But you do the best you can with the data you got, and there's some data out there suggesting 20 is a reasonable threshold, probably pretty conservative threshold, probably the true upper limit of normal for the mast cell count is probably a good bit less than 20. So this is estimating conservatively, but for right now, it's what we got. If anybody out there wants to do studies that will better pin this down, then great. And this is just more data demonstrating the utility of these counts. There was a paper recently talking about another way of doing the 117 counting that might be helpful, but this is just a proposal. There's not been no follow-up research on this yet. GU tract biopsies can be looked at. There's less data here, but experts in this area have told me they feel the same 20 per high power field threshold is applicable in the GU tract biopsies as in the GI tract biopsies. Think about other diagnoses. Obviously, with all these diagnoses that are listed here, there are reasons why the symptoms might overlap a fair bit with what you could see with mast cell disease. So just do some careful diagnostic thinking. And if you have reasons to suspect these other problems, then go run the workup. So after years of mystery, the patient now has a new diagnosis of MCAS. What now? And that leads us to prognosis and treatment, and that will be that'll be the subject of our final talk in this 3-talk series a week from today. So we need to improve our diagnostic techniques and get higher quality diagnostic criteria. And that's it. So thank you very much. Be happy to take questions. And because it's the weekend, I'm happy to run with questions as long as the hosts are willing to run.
All right. Well, thank you so much. So I guess I'll go ahead and get the questions going that we have. I'll start off with what's in the Q&A, and we also had a couple from panelists, and then also other panelists may also actually do it. And if we end up with a lot of time left, I will also start tapping into the questions from last time that didn't get answered yet. And so we'll, because there's some good ones in there too. So the first one we have is from one of our guests today. So it'll be Athena. Let me see if I can. There you
Thank
you're on
you.
there. Yeah, go
Thank
ahead.
you. Could I ask for your approach as to key drivers with patients that are experiencing biomechanical issues, whether thoracic outlet syndrome or, for example, craniocervical syndrome or instability, and how these drivers play a role in as a driver of the inflammation and how your approach would change to treatment of these patients?
Those are some very tricky patients to handle because it's a real issue, a real chicken and egg issue. I don't think there's, at least based on my experience, I don't think anybody could fault me for strongly suspecting that it's ultimately the mast cell disease that's what's driving the inappropriate development of the soft tissues that ultimately results in what we clinically call, craniocervical instability. But there's also no question that once you have the misdevelopment of those tissues, the mechanical consequences can easily further uh, drive a whole range of downstream problems that oftentimes just kind of circle back to further activate not only your normal mast cells, but you can imagine even more egregiously activate your dysfunctional mast cells. So if you have a patient where the clinical presentation is suggestive that CCI is part of the mix, then fine, you have to go doing the evaluation that's appropriate for CCI. But when it comes to treatment, I think at least some of the CCI surgeons out there are beginning to learn that unless it's an absolute imminently life-threatening emergency, you probably should not go trying immediately to do any surgical correction of the CCI until you get at least some pharmacologic control over the MCAS, because otherwise you take a patient through this major surgery and the mast cells, you have to have decent mast cell function to heal properly. Yeah, healing is another aspect of tissue growth and development, and poor healing is one of the most common complaints you hear across the MCAS patient population. So if you don't have at least some control over the mast cells and you go through a big surgery, nobody's going to be surprised if the acute and chronic outcomes of the surgery are nowhere close to what you might hope for. So you go back and forth, you do a little bit with the mast cell therapeutic work and you get them somewhat better. Then you do maybe the CCI work, or if you found any infections in the patient, you try to address the infections. And then maybe you circle back to do a little bit more with the mast cell targeted treatment. I wish there were some easy, recipe or protocol for this, but every one of these patients is quite unique and distinctive, and you follow your clinical gut intuition as best you can with each patient.
Thank you, Dr. Afrin, for addressing the different etiologies and how they link in to the treatment along the way, which is not only intricate, but requires a patient-centered and very, I want to say slow or patience in the approach. Thank you so much.
You've got to take into consideration what your best estimate is of what these patients are able to tolerate in terms of various treatments you'd like to give them. And also keep in mind that the moment that either the patient or the doctor starts making 2 or more changes in the regimen around the same time, and then the patient gets either better or worse, you don't have any idea which change is making the patient better or worse. It's a real mess to sort it out at that point. So yes, everybody faces emergencies now and then, but where the patient and the doctor have no choice but to make multiple changes around the same time. But as much as is possible, which actually is the great majority of the time, both the patient and the doctor, and it's usually the doctor who has the greater problem with this, but both the patient and the doctor have got to have the patience to make one change at a time. And it's fortunate that most changes we make in trying to treat this disease does not take long at all to figure out whether it's going to be significantly helpful for the individual patient's particular variant of this disease. So it's not a lot of patience that's required, but you do have to have some patience in optimally managing this.
Thank you. Excellent. Thank you.
All right, so the next question comes from somebody who's listed as an anonymous attendee, so I'm not able to bring them on to answer live, but I'll ask the question for them. So based on your outcomes, are upstream treatment options more beneficial?
Again, I'd have to say that depends entirely on the individual patient and the individual problem that you're treating. I mean, I'll give you an example. There are plenty of these patients in whom it actually is the mast cell disease that is driving their chronic hypertension or their hyperlipidemia. And if it could easily be the case that various mast cell targeted treatments might get the blood pressure under better control, get the lipids under better control, but you can't deny either the efficacy of antihypertensives and statins and other hypolipidemics. So there's nothing wrong with trying other drugs that have been well established to usually be helpful for various kind of superficial problems that can be seen in different mast cell patients. But if you try the sort of standard drugs for one aspect of MCAS in a given patient, or one aspect or another, if you try the standard drugs and you're just not making the progress you'd expect to be making, you'd like to be making, then you got to go asking yourself, what am I missing here? And you might be missing that underlying issue, the MCAS, and at that point, treating the underlying issue may be more helpful, not only for that one particular superficial issue, but quite possibly a whole range of other issues. I had this, just give a quick anecdote. I had this young man, I've been seeing him for a number of years, was having a good bit of difficulty controlling some of his symptoms, other symptoms that come under control, but there were some things that were just not doing well. That it was hard to control the blood pressure. He had these spells at night of ravenous hunger, and had a lot of diaphoresis. And we had made a little bit of headway with antihypertensives and muscarinic receptor blockers and some other things, but no real game changer therapies. And then there's been some data coming out lately regarding the GLP-1 agonists and their reasons to think these drugs might be very helpful. in at least some MCAS patients. So went ahead and tried that in this patient, even though he does not have the diabetes or obesity for which these drugs are FDA approved. And son of a gun, within 48 hours, the hunger is gone. The blood pressure is normalized for the first time in a decade. The night sweats are just gone. And it's very clear. I mean, yes, there are GLP-1 receptors on lots of other types of cells too, but there also happen to be GLP-1 receptors on the mast cells. And in this patient, it's the mast cells that were driving all of his troubles. So here was another therapeutic avenue for potentially gaining more control over his inappropriate mast cell activation, a totally different mechanism than what histamine receptor blockers or leukotriene blockers or anti-inflammatories can bring. So you apply a drug that gets more at the root issue in some novel fashion and look at the broad range of benefits that can quickly emerge.
No, thank you. Our next person coming up will be Laura Gray. So Laura, looks like you've got a couple questions in here if you want to go ahead.
Hello.
Yes,
Hello.
we can hear you.
Hi. Yeah, so I just wanted to ask, and I think it might be a silly question, but is this linking in, is the inability of mast cells to hold on to heparin within them possibly causing our platelets to clump together in long COVID? Is that one scenario that could be possible?
Not entirely sure I understand the heparin part of that question, but I will point out that there actually has been literature for about 3 years now that has been developing the case for how the more severe cases of acute COVID, the so-called hyperinflammatory cytokine storms that you see in roughly 15 to 20% of acutely infected COVID patients, as well as a substantial fraction of the long COVID patients, that what's actually going on in those patients is that it's an underlying MCAS that you can imagine in most of those cases is just not clinically recognized by their treating doctors. And in fact, because COVID is such a major stressor for immune cells, particularly dysfunctional mast cells, that COVID infection could easily be one of these physical stressors that sparks an escalation, a fundamental permanent escalation in the baseline level of misbehavior of the dysfunctional mast cells. So I long ago lost count of the number of these patients who I've heard about who have been diagnosed with long COVID, and then they go taking mast cell targeted treatments, and it substantially helps them. And if you go back and do a deep dive in the history, and those, many of them, of course, tell you, oh, I was perfectly healthy up until I got COVID. But no, I see Dr. Azola shaking her head there. She's seen the same thing I have. You do a careful history in these patients. No, they have not always been perfectly healthy. They've had a long run of issues, admittedly much more modest issues than after they got COVID, but they've had a long run of multi-system inflammatory plus minus allergic plus minus dystrophic issues that, to anybody who knows what MCAS, anybody who's learned what MCAS looks like, yeah, these are patients who have had MCAS. They've had it a long time. Just was relatively modest. And then, unfortunately, they came to suffer this infection, and it was their uncontrolled dysfunctional mast cells that were getting wildly, inappropriately amped up by the virus, and all that stress then just drives a further escalation of the disease, additional mutations and permanently heightened misbehavior of these dysfunctional mast cells. It's been very interesting. You know how prevalent COVID is, how contagious it is. So no surprise that among my population of thousands of mast cell patients, I've had plenty of patients who were already diagnosed and treated for MCAS before they got their COVID infection. And so far, and maybe I'm just seeing a biased population, maybe I'm just too horse blindered to recognize what I should be seeing, but honest to God, all the many patients I've seen so far who got COVID after their MCAS was already diagnosed, treated, and brought under halfway decent control, not a single one of those patients came to suffer either one of these severe acute forms of COVID infection, and not a single one of them developed long COVID. Okay, so the issue for these MCAS patients vis-a-vis COVID is not whether they have dysfunctional mast cells. The issue, as far as how severe the acute infection and whether they're going to get long COVID, the issue is whether their dysfunctional mast cells, how well controlled those dysfunctional mast cells already are at the time they come to get the infection. And if the cells, if the disease, if the MCAS has already been recognized and diagnosed and treated halfway effectively at the time they get the infection, then they're going to tolerate the infection pretty much as well as anybody who doesn't have MCAS. They'll have some symptoms for a week or two, and it'll settle down, and that's it. You're back to baseline. So the issue is whether the dysfunctional mast cells are insufficiently controlled at the time the virus sets in. And it's not just COVID, it's pretty much any infection.
Okay, thank you. I don't know whether I'm still on speaker.
Yes, ma'am.
Thank you. I am one of those patients who's had lots of problems after COVID. And the other question I wanted to ask was just about testing for MCAS with patients who are already taking mast cell stabilizers and various other things that are treating their disease, their problems. Do you ever get to the stage where you just think it's too cruel to stop those things, and it's so clear that they have MCAS?
Oh, I'm aware there are a number of doctors out there who are making what you're alluding to are clinical diagnoses of MCAS. And, you know, different doctors have different styles. You can certainly do that if you want, but I have had the experience too many times to count of these patients. You know, they might get a diagnosis from me, but then they're going to be living decades longer. They're going to be seeing lots of other doctors for lots of other reasons for the rest of their lives. Those other doctors typically have no familiarity with MCAS, and they need to be convinced of the reality of this, the truth of the diagnosis. And you don't convince other doctors of that by saying, "Oh, somebody clinically diagnosed me with this." It's the laboratory evidence that's going to convince other doctors that you really have a problem with the mast cells. So I found it best in the long run for these patients to acquire the laboratory evidence in doing this. And furthermore, I'll point out that most of the drugs that are useful in controlling mast cell activation, you don't have to come off most of those drugs to go through the testing.
Yes.
You know, you have to, if possible, you have to come off the non-steroidal anti-inflammatories for a few days in advance of the testing. But there are other things that can be done for pain in that interval. You have to come off vitamin C, D, and E supplements for about a week in advance. But who can't come off a vitamin C, D, or E supplement for a few days? Yes, there are
What about
occasional patients who can't come off their proton pump inhibitors. So, okay, a PPI is going to interfere potentially with one test, the chromogranin A test. So big deal. You still have a lot of other tests you can run, but all the other drugs, the antihistamines, the anti-leukotriene, the leukotriene blockers, and so on and so forth, flavonoids, they're not known to interfere with the tests for this disease. So no, I don't ask my patients to come off their antihistamines. In fact, I'm amazed whenever I hear from my patients that they went off to an allergist to get allergy testing done, and the allergists have been trained. They absolutely insist the patient must come off all H1 and H2 blockers for about a week in advance of going through allergy testing. And so many of these patients just decompensate horribly within 24 to 48 hours of stopping their H1 or H2 blockers. And I just don't see the purpose in it. So again, I'm not an allergist, but
Well, thank you.
All right, so next question, Ellie is going to be bringing up one of the questions from the Q&A from one of the anonymous attendees. Ellie, whenever you're ready.
Okay, here's a multi-part question that starts out with a statement. In general, people with MCAS benefit from nicotine patches. Looking at it from a lens of an MCAS expert, do you have any theories why?
well, first of all, I'm not sure I agree with the premise there. I have seen occasional MCAS patients who have clearly benefited from a nicotine patch, but if there is literature out there, published peer-reviewed literature showing that most MCAS patients benefit from a nicotine patch, this is news to me, and I would love to see that paper. Now, that having been said, is there a mechanism by which nicotine might be able to help control MCAS? Absolutely, there is. There are nicotinic receptors on the surface of the mast cell. Doctors go through 10 years of training, and in 10 years, they get 1 minute of teaching about mast cell biology and disease. And in that 1 minute, they get taught that mast cells produce two mediators, tryptase and histamine. I mean, honestly, how much trouble could a cell cause if that's all it's doing? So you can imagine why doctors are biased to thinking mast cells can't cause much trouble, other than maybe anaphylaxis if too much histamine gets released. So they're taught that the mast cells produce two mediators and they have one receptor, the IgE receptor, which is the mechanism by which they get wrapped up in allergy and anaphylaxis. But in truth, the mast cell has been documented by the biologists to produce more than 1,200 mediators, each of which has a huge range of effects all throughout the body, and to express more than 300 receptors on its cell surface. So the potential for even normal mast cells to interact with other cells in the body and other drugs is just enormous, let alone what dysfunctional mast cells might do when these various molecules come to engage with these receptors on the surface of the mast cell. I'll give you a couple of examples. The cannabinoids, why are the cannabinoids helpful in many of these patients? Well, yes, you've got cannabinoid receptors on your neurons, but it turns out you've also got cannabinoid receptors on all your mast cells. Why are benzodiazepines helpful in these? Yes, many of these patients have anxiety, both reactive to just feeling crappy all the time, as well as primary anxiety that's actually being driven by the inflammatory mediators being inappropriately released from the dysfunctional mast cells that are directly abutting their central neurons. So when those mediators come to hit on the adjacent neurons, you get a whole range of neurologic and psychiatric and cognitive and dysautonomic issues. So the benzos, yeah, we all learn early in training they can help settle down anxiety because they engage with inhibitory benzo receptors that are on the surfaces of all neurons. And the neurons are ratcheted up in their activation state when you have anxiety. So if you ratchet down the neuronal activation state, you can reduce anxiety. All that's true, but it turns out you've also got exactly the same benzo receptors on all your mast cells. So when a mast cell patient takes a benzo, is actually getting a twofer, ratcheting down the neurons and simultaneously ratcheting down the mast cells that are what's been driving the heightened neuronal activation in the first place. So, you got just so many molecules that have potential for interaction with the mast cells. Potentially. I mean, yes, some molecules might actually ratchet up a mast cell's activation state, but nevertheless, you got so many drugs out there. We are blessed with a boatload of drugs, which have already been found helpful in various mast cell patients. That's not the issue. The frustration is that the state of the science in this area is so immature that we don't have even a single study yet, not one study yet that allows us to reliably predict which of these many different drugs, which have been found helpful in various mast cell patients. No way at all yet to reliably predict which of these drugs is best going to help the individual mast cell patient. So this is where it really gets down to clinical art and experience in trying to figure out the particular sequence in which you're going to go about trying these different drugs in the individual patient.
We should let you know that Renegade Research has been involved in a self-experiment of nicotine patches, and I don't think the data is published yet, but we'll be sure to include you in what we found.
I would love to see that study.
This person also has observed in the people that did well that they could go back to eating nightshades with no provocation. So the next part of the question.
Mast cell patients, you get their mast cell disease under at least some degree of control, and many of the reactivities they have long been suffering just simmer down, whether it's food or environmental or whatever their reactivities may be.
Could this thing called a Herx or Burks reaction be MCAS related? Some kind of a MCAS healing flare?
No studies yet that I'm aware of that have specifically investigated that, but based purely on my experience, I'd say it's almost certain that Herx reactions are acute flares of dominantly the mast cells. I mean, keep in mind, when a mast cell releases its mediators, those mediators are then going to immediately start hitting on lots of other cells in the body, including many normal inflammatory cells. So yes, some of that reaction is coming about from, normal immune cells that are further activating. But if you're asking why were they activating in the first place, I suspect it's the dysfunctional mast cells that are inappropriately reacting to the treatments that are being applied in these patients, and that inappropriate reaction by the dysfunctional mast cells is then what's driving directly or indirectly all of the symptoms that we come to clinically label as a Herx reaction.
Right. I think it's back to you, Rochelle, for the next person.
Yep. All right. So our next one, I'm going to pull from our, again, from our Q&A here. And so this next one comes from Nita Jane, whenever you're ready.
Hi, is this okay?
Mm-hmm. Yes, perfect.
Okay, perfect. I just wanted to ask for patients who do have gastrointestinal mast cell involvement or that infiltration that might be seen on that CD117 stain, what range of like calprotectin levels or secretory IgA levels do you observe in these patients? Is it sort of like a middle ground where it's obviously higher than what you might observe in IBS without mast cell involvement, but maybe lower than what you see in IBD patients? And is there any correlation with distension or bleeding? And do you see patients who might be misdiagnosed with a compression syndrome like SMAS or MULS?
There certainly is potential for misdiagnosis of the vascular compression syndromes. And also with regard to the bloating with this disease, episodic bloating, sometimes chronic bloating, is very common with this disease. The specific mechanism remains quite elusive. But the first part of your question, checking fecal calprotectin levels that can be a signal of GI tract inflammation. I actually have not seen any reliable patterns in calprotectin levels. I understand why, you might suspect they'd be more reliably elevated, but I've not actually seen that in practice, and I don't know why.
Gotcha. Yeah, I was wondering if maybe it's because you see, like you were saying, that the mast cell concentration tends to be higher in the duodenum and the ileum, and I think calprotectin maybe reflects more of the colonic count, and could that be a potential reason why it's not as elevated as you might think?
Good thought. Let's run the study and find out.
All right, solid. Thank you so much.
I love your answer for a lot of these. Is like, well, let's run the study and let's find out. That's always a fun one for that. So we have a question here from one of our panelists that isn't able to speak right now, but I will go ahead and ask that. So do you modify your drug approach depending on the markers you find elevated? For example, high PGD2, do you treat differently than, say, if it's leukotrienes, and whether the role of the drugs like low-dose heparin or other anticoagulants have a role?
I will readily admit that I often fall to temptation that when I see what appears to be an easy target in a mast cell patient, that I just instinctively think about prioritizing treatments for that target. So I had a patient just yesterday who actually, in her diagnostic work, she was actually a new record setter for me, the highest leukotriene E4 level I've ever seen. And coincidentally, in the prior interval, she had been started by one of her local doctors on montelukast, and she was already gaining some improvement. But with a level this high, and with montelukast being a competitive receptor blocker for the leukotriene receptors, obviously it would make all the sense in the world to try more intensive dosing and frequency of a leukotriene receptor blocker when there is so much of the leukotriene mediator that's floating around in her. So yeah, I'm going to be tempted to try to prioritize experiments with various leukotriene targeting treatments, receptor blockers, and leukotriene synthesis inhibitors in that patient. And similarly, if I see somebody with a really high histamine level or N-methylhistamine level, sure, I'll be thinking about getting more aggressive with antihistamines in those patients. If I see a high prostaglandin level, I'll be thinking about, aspirin in those patients. I fall to temptation like everybody else does. That having been said, have I yet seen in practice that patients with an elevated leukotriene level are actually gonna more reliably respond to a leukotriene blocker than any other type of drug I might try in them? Nope. And have I seen plenty of patients who have high histamine levels and yet they demonstrate relatively modest results with H1 blockers and H2 blockers? Yep. And it's just a reminder that most of the symptoms you're seeing in these patients, it's not coming from the modestly elevated levels of the mediators we're testing for the diagnostic work. The symptoms are coming from other mediators that we are not presently testing. And in fact, I'll point out that nobody has shown yet that there's any utility whatsoever to following these diagnostic tests over time to sort of see if you can use them as an objective marker of response to treatment. And no, the level, whatever mediators you find elevated at diagnosis, they quite often continue to be elevated, even though the patient is getting wonderfully better with various mast cell targeted treatment. And it's just another point of evidence that the symptoms are by and large not coming from the mediators we're testing.
Thank you. All right, so next person, sorry, this cat never comes out here. And then this cat, of course, you know, during something like this, that's when she's got to be here. Never fails, right? So next, because, you know, we do have, you know, we've been here for a while, so I'm going to try to ask a question from a person who is still on the line. So I'll go, because we have had a couple people that have had to leave because it gets a little long for them. So the next person is going to be Suzanne Ducker. If you are able to go ahead.
Hello, doctor. I really appreciate what you've been talking about. My question was, what I obviously follow that pattern of history of a lifelong allergy, GI anaphylaxis that I've had since I was 4 or 5, and I'm now 70. But the curious thing that I've noticed about the long COVID I got in 2020 that started with urticarial rash that was reappearing every hour for about 5 months was that all my regular allergy symptoms are gone since then. I'm now in bed with long COVID, quote unquote, with the dysautonomia. Is there a way, having heard you, is there a way that the MCAS stuff kind of morphs into something more serious? We now have potential autoimmune going on, giving me double vision. We're looking for things. Are we missing something major here? Because I have very little health care. I mean, even though I'm in a city, it's been hard to access anything.
I think the major thing we're missing are the 20% of the general population that has MCAS in one fashion or another, and yet most doctors have never even heard of this, let alone developed any significant familiarity with it. Sometimes in a mast cell patient, this isn't very common, but sometimes some symptom they've been dealing with for a long time actually does seem to go into a sustained remission. But probably what's happening in that patient is it actually does commonly happen that when that happens, it's kind of coincident with development of other new issues. So probably what's happening is that some new mutation is developing that is kind of simultaneously driving the new symptom, but also as another downstream effect of that new mutation is kind of nullifying whatever mutations were there before that were driving some of the previously long present symptoms. You know, we would love in patients like you're describing yourself to be able to do the genetic testing, do the mutational analyses in the mast cells and follow them over time to see how the mutational profiles are changing over time, how that correlates with changes in the symptoms over time, correlates with how the effectiveness of different drugs can change over time in some of these patients. But my estimation from what I've been seeing in the laboratory market it's going to be at least 10 to 20 years before the testing that the research labs can do to identify the mutations in these mast cells, before this testing begins to migrate from any of the research labs to any of the clinical sequencing laboratories. You're 70, I'm not sure it's going to happen before
Yeah.
there's no chance anymore. But for somebody who's, 20, 30, 40, I think the odds are good that the sequencing technologies probably will get to the clinical laboratories. And when that happens, listen, the first clinical laboratory anywhere on the planet that begins to offer this highly specialized genetic testing that can identify the mutations in the mast cells, I want to send every one of my thousands of mast cell patients to that laboratory on day one. It'll be a very long line at the lab that day, but I want to start learning which mutations are present in which patients to figure out which mutations correlate with which symptoms, and even more importantly, which mutations seem to respond best to which particular treatment. So we can start getting away from the whole trial and error business with the treatment and start much more smartly and reliably predicting which treatments are most likely going to help which patients based on which mutations are present in their mast cells. But it's going to be a long time before that testing is available.
Well, I thank you. Thank you very much, everybody, for doing this televised cast. Thank you.
Good luck to you.
All right, and then Ellie is going to go ahead and now I got a dog squeaking a toy. Ellie's going to bring up one of the questions from one of the anonymous attendees. So go ahead, Ellie.
Okay, I think I'll read two at once. They seem short. Is it possible for a patient to have both HAT and MCAS? And is severe anxiety one of the symptoms of MCAS?
Yeah.
Let's answer the second one first. I think I actually already answered it, that there's no question this disease can drive a huge range of neuronal issues, not only peripheral neuronal issues, but a huge array of central neuronal issues. And really, it's just entirely a matter of which particular mast cell mediators are coming to impact which particular central neurons as to whether the end result is going to of that interaction is going to be a neurologic issue of one sort or another, or a cognitive issue of one sort or another, or a psychiatric issue of some sort, or a dysautonomic issue of some sort. The devil's in the details in sorting all that out. But anxiety, the anxiety and mood disorders, so anxiety, panic, obsessive compulsion, those are different forms of the anxiety disorders, and the mood disorders, depression, bipolar disease, and so on and so on, particularly bipolar type 2. The anxiety and mood disorders are some of the most common psychiatric issues that we see in folks who have MCAS. And you get the MCAS under better control, and quite often these neuronal issues very quickly start getting better, many times even without any actual psychiatric treatment. And oh, by the way, the SSRI drugs for the antidepressant SSRI drugs, they address a receptor on the neurons, the so-called serotonin reuptake element. The SRE receptors on the neurons, and guess what? You got exactly the same receptors on the mast cells. Anyway, so if you're wondering how an SSRI drug could help not only depression, but an awful lot of other physical issues in these patients, yeah, you're getting a twofer with the SSRI drugs too. As to the first question, absolutely yes. HAT is by definition just having one or more extra copies of the TPS-AB1 gene for making tryptase. And you can easily have extra copies of that gene and have MCAS. But in those patients who have both, my estimation is it's not the mildly elevated level of tryptase that's being driven by the extra copies of the tryptase gene that's really causing any of their symptoms. And instead, it's other mutations in various mast cell regulatory genes inside the dysfunctional mast cells that are what's actually driving the misbehavior of the mast cell to release all these other mediators that are what's actually driving all their symptoms. Hope that makes sense.
I think it does. So next, Alba has a question again. So yeah, go right ahead.
I don't think I've been able to ask it, but I just wanted to piggyback on that because it brought up what my burning question is from a clinician side. I've just been starting to, over the past 3-4 years, check for these markers on my patients and kind of trying to understand what the levels are. You mentioned mildly elevated, very elevated. It's just for personal reasons. I actually had a recent patient with like a 31.7 for tryptase. Symptomatically, he presents clinically as MCAS. I had him seen by hem-onc. They didn't want to do the biopsy. I haven't sent the genetic testing for the alpha tryptosemia, but I was wondering, what do you think? What do you make of those levels? When do you throw a threshold?
First of all, any test could be abnormal or wrong, once by chance or error. So the very first thing I would do is repeat the tryptase.
Yeah, it was 30 when I repeated it.
But if it's persistently above 20, then with all due respect to the hem-oncer who saw the patient and decided investigation for mastocytosis was not required, I respectfully disagree. And I think the patient should be sent to another hematologist and another and another and another until at least 2, not just 1. Most marrow diseases, we go looking for with the marrow biopsy. 1 biopsy, a unilateral biopsy, is sufficient for looking for those diseases. That is not the case with mastocytosis. In mastocytosis, the aggregates of the mast cells that are one of the hallmark features of mastocytosis, it is a patchy distribution of these aggregates. And the literature is clear that as much as a sixth, 1/6 of all mastocytosis patients, you do 1 marrow biopsy in them, you will not find evidence of the mastocytosis. So this is one of the unusual marrow diseases where you actually do have to do multiple biopsies, and multiple usually means 2, and it can be done in the same procedure. The patient doesn't have to come back for multiple procedures. They get sedated, and the doctor first does a biopsy on 1 posterior iliac crest, and then while the patient is still sedated, he does the biopsy on the other iliac crest. But you have to do 2 separate biopsies for it to be an adequate marrow examination for mastocytosis, and you have to be sure that all the appropriate molecular studies, the special molecular studies to probe specifically for mastocytosis, all that has to be communicated. You have to communicate to the pathologist this is what you're looking for, so that the pathologist can be sure to do all the right testing. Can't tell you how many evaluations I've seen where they just had a routine marrow done and the pathologist did not do what really needed to be done to look for mastocytosis. And it's unfortunate because then the patient has to undergo the procedure again. So I would send that patient back to another hematologist to get the appropriate studies done. But I also would be sure to say, and listen, this testing is easy to obtain. The company is in Houston. Their name is Gene by Gene. and you can look them up on the web, and you look for the tryptase CNV, the tryptase copy number variant test. You can either send blood, we're talking about a germline mutation here. This is something they inherited. So by definition, it's in every cell in their body. Yes, most cells don't make tryptase, but the genes are still there. Okay, so you don't even have to get a blood test. If you want to just have them take a swab, oral mucosal swab and send that off, you can do that. And so regardless of what sample you send, they'll get you a report in a month, and it's pretty cheap. I think it's like $150. And so my point is, it is possible for your patient to have both HAT and mastocytosis. So you got to go looking for both. So the HAT, as far as we know, has no clinical significance whatsoever. Nobody has ever been able to define been able to show that having a little bit of extra tryptase production actually causes any problems. Yes, many HAT patients have many symptoms that are classic for MCAS, and you go testing them appropriately for MCAS, you can define MCAS in them, and that's because they have both HAT and MCAS. But it's not to say that the tryptase, the TPS-AB1 redundancy is what's actually causing their symptoms. It's other mutations that are what's causing other aspects of mast cell activation, releasing other mediators that are what's causing their symptoms.
Super helpful. Thank you. Appreciate that.
Okay, so I have another question from one of our panelists that isn't able to come up. And then also, before I ask that though, how long are you willing to go? Because we still have several questions coming up.
That's fine. I got nothing else on my schedule today. I do
Okay.
have some research work I'm trying to get to, but no schedule for that. So we can keep going.
Okay.
Listen, I learned a long time ago how important education is. So if there are folks out there who have questions and they've been willing to hang in for 2.5 hours so far, I got to respect that, and I'll honor that, and we'll keep going until the last question's answered.
Okay. All right. So the question I was going to be asking about was things like how might neurovascular issues post-COVID, things that might cause like hypoperfusion, could those be related to MCAS presentations in that population? And then also with that, what might be the role of some anticoagulants like a low molecular weight heparin or something?
Right. Listen, if you've got a variant, let's take the second question first. If you've got a variant of MCAS that has ramped up, procoagulant activity in you, and you're having repeated thromboembolic phenomena, multiple DVTs, pulmonary emboli, whatever, you need to be treated. You need to be chronically anticoagulated. For that, you do need to have your doctor go looking for potentially any other cause of chronic thromboembolic phenomena, antiphospholipid antibodies or any of the relatively uncommon inherited hypercoagulable syndromes, if that's appropriate in the individual patient. But bottom line is, if you're clotting too much, then you got to do something about it. Now, maybe treating the MCAS will all by itself settle down the clotting enough that you don't need to be taking don't need to be taking specifically an anticoagulant any longer. But you just have to work through that over time and see what the patient ultimately needs. The first part of that question, the neurovascular stuff, can MCAS drive hypoperfusion? And actually, MCAS can not only drive hypoperfusion, but also hyperperfusion. And in fact, many of you folks have already seen many examples of hyperperfusion because these patients often develop flushing or redness rashes about red rashes about various parts of the body. Why do you think they develop these patches of redness? Why does the skin turn red? It's an influx into the cutaneous microvasculature of a lot more red blood cells. Um, and that's why the skin turns red, and you get this acute influx of red cells into one patch of skin or another because the small vessels are dilating. Why are the small vessels dilating and allowing more blood flow into that area? Because where are the mast cells? They're at the environmental interfaces and directly abutting all vessels and all neurons. And there absolutely are mast cell mediators, very potent mediators that can drive vasodilation. And there also are other mediators that very potently can drive vasoconstriction. So depending on which mediators happen to be getting released inappropriately at any given time in any given place in the body, that's what might determine whether you get vasodilation and therefore a flush or a blush, a rash, or whether you might get pretty intensive vasoconstriction. It might be venoconstriction, it might be arterioconstriction. In fact, you might be interested in looking up this eponym in the medical literature, Kounis syndrome, Kounis syndrome, which is a syndrome in which it's a mast cell driven syndrome in which an artery in one place in the body or another comes to acutely constrict so severely, quite often completely shutting, that you get such a restriction of blood flow that the tissues downstream from that constriction point, they're starved for blood. They die, they necrose. And if this happens in a coronary artery, you get a heart attack. If this happens, and that's Kounis syndrome type 1. If this happens in a cerebral artery, you get a stroke. This is Kounis syndrome type 2. And if you get this happening in any other arterial bed anywhere in the body, it all just gets lumped together under Kounis syndrome type 3. So hypoperfusion. Yeah, lots of ways that mast cell disease can bring hypoperfusion.
I think you answered a question that I had that I wasn't going to quite ask yet, but about the Kounis syndrome type 2. I know somebody recently who had a mysterious stroke. Then they're looking at some sort of vasospasm, may have been some issue with it, arterial vasospasm in the cerebral artery, and so it's a. So I'm like, yeah, I'm gonna pass that one right on. I told his doctor to be here today, and he's not, so I will pass it on.
Antihistamines. You get somebody who comes in with, you figure out it's Kounis syndrome, H1, H2 blockers immediately.
With Kounis syndrome, is there any way to track to see that that's what it is after the fact, if the artery has or vein has
Well, it's
actually
basically a workup for MCAS, you can
Okay.
go looking for an elevated level of tryptase, but again, it's not a great marker for mast cell activation.
Yeah. Yeah, I was just kind of like, that just worked on that one. So up next, Ellie is going to ask another one of the anonymous questions. And then after that, Nick will come on with his question. Ellie, you're muted.
Your microphone is muted.
Thank you. Thank you. I've heard you speak elsewhere that you think GLP-1s might work as a mast cell stabilizer. a lot of anecdotes in the patient groups for the Mast Cell Society for patients on these medications, it being that their asthma is diminished, eczema, and other symptoms. Can you elaborate on whether you think this is a worthwhile treatment pipeline for patients that are on quite a bit of the conventional MCAS drugs?
Yeah, my clinical suspicion is yes, but let's be explicitly clear. There have been 0 studies of this so far. So there is no scientific evidence yet of what the success rate with those drugs in mast cell disease patients are. Is there already identified, scientifically identified, a potential mechanism by which those drugs could help in mast cell disease? Absolutely, yes. We know there are GLP-1 receptors on the mast cells. But in terms of a clinical trial of these drugs in either mastocytosis patients or MCAS patients, no. I'm aware of only a single case report to date. And I don't even think it was in the peer-reviewed literature. It was in one of these throwaway journals that you got plenty of in the medical industry, where there was a case report of a patient with indolent mastocytosis who also had, I think it was obesity. And it was decided to try to treat the obesity while the mastocytosis was also brewing there. And the doctors were astounded to see not only the weight loss, but a huge range of other mast cell driven symptoms that immediately got better in that patient. And that is the only published report to date I'm aware of the use of a GLP-1 agonist in any form of mast cell disease.
I know you've mentioned in part 1 about the COPE library mast cell mediators page at cells-talk.com. And we want to support and mention that site because we don't want it to go away. Does it also have a list of all of the receptors?
Yes, it does. It absolutely does. And I will tell you this. Funny that you brought this up and that the question was worded the way you worded, because I have heard from the proprietor of that site. He has been working on this site so hard for so long, honestly, a quarter century, and has gained so little recognition for his work that he recently made a decision that if he doesn't get at least 100 additional subscribers, I think right now he has maybe 5 or 10. That's it. It is a travesty. And if he doesn't get at least 100 more subscribers in the next 6 months, no, actually, he told me this 3 months ago. So I think it's like August or something he's targeting. If he hasn't gotten at least 100 new subscribers by August, he's shutting it down. And oh my God, what a loss that would be. So now that absolutely places you folks at Renegade under 0 obligation to do anything about that. But I just want to make you aware that it's a phenomenal resource that may, after a quarter century going unrecognized, may just go away in very short order.
Yeah, we've been beating the drum a little bit on Twitter, and I will drop the link in the chat.
So, given how many people have MCAS and might benefit from the knowledge there, and given how many doctors are seeing these patients every day, even though they don't yet really recognize that, you'd like to think out of the tens of millions of people who could benefit from the information there, that you could find at least 100 people who would be willing to spend $10 a month to have ongoing access to that treasure trove. It's not just mast cell information, it's the whole human cytokine panoply that's unbelievably well organized there, and it just would be such a shame if it goes away.
I think you have a discount or a grandfather rate. It's $15 a month now. But it's still the best bargain out there.
Best bargain, best knowledge bargain you could ever get. At least if you've got mast cell disease or you treat mast cell disease. I can't tell you how many doctors I've shown that site to. And I just start scrolling through that mast cell page, and I'm scrolling, and just mediator, receptor, and I'm scrolling, and 2 minutes of scrolling, and it's all alphabetically organized. 2 minutes of scrolling, I'm still at the B's or the C's, and then the light bulb turns on and they start realizing, oh, this is not just a matter of tryptase and histamine and one receptor, the IgE receptor. This is incredibly complex. Look at the potential these cells have for inappropriately releasing various mediators that can drive this phenomenal array of issues all throughout the body. And so the light bulb turns on and they suddenly get it.
Hey, back to you, Rochelle.
Yep. Sorry, I just had another message pop up right at the same time. So, Nick, you said you had a question you wanted to ask, so go ahead.
Sweet. Yeah, thanks for your talk today. Yeah, as MCAS seems to get worse as people age, MCAS suffers a predominantly female and is quite a heterogeneous presentation. What would be your explanation for this? Do you think it's something to do with the corticotropin releasing factor and HPA axis, or would you think something like X chromosome inactivation being skewed would make a better explanation? Or
there are actually two questions in there: getting worse with age and the female to male skewing. And with regard to the first question, the reason it probably gets worse with age is this notion I described a couple times earlier, where because this is largely a mutationally driven disease, but not inborn mutations, these are acquired mutations. But from time to time throughout a mast cell patient's life, typically shortly following a major physical or psychological stressor, there's all these cytokine storms that flood into the body whenever you're under stress. And we're beginning to learn that these various cytokine storms can sort of interact with more fragile genomes to induce additional mutations. And if you happen to have a conflagration of events such that an additional mutation gets introduced into a stem cell, and specifically introduced into a gene in that stem cell, a gene that is of regulatory importance to a mast cell, then obviously all of the mast cell progeny of that mutated stem cell will then bear the same mutation, and those mast cells will start misbehaving. So over a lifetime, as these patients come to be subject to various stressors at various points in time, they develop additional mutations in some of their stem cells, and that then leads to emergence of mast cell progeny of those mutated stem cells, mast cell progeny that have over time more and more and more of these mutations, and that leads them to misbehave more and more and more. So that's probably why the disease gets worse over time. As far as the female to male ratio there, multiple studies have pretty consistently shown that it's about a 4, maybe 5-to-1 ratio, women to men who suffer this. And there are probably a couple of factors that need to be considered in trying to explain that. Number one, let's be honest, There may well, this has not been formally studied, but nevertheless, there may well be some social factors here. Because the fact is, the great majority of the symptoms these patients have, they are not imminently life-threatening and not severely deforming. And in general, and this is well studied, most men will not go to a doctor to be evaluated unless they have a symptom that is so bad they can't work or go to school. They are disabled, or they have some severe deformity, a cosmetic deformity that makes them less attractive to the opposite sex. That's what drives men to the doctor. Women, and I'm not making any comments here about whether this is right or not, but the fact is women go to the doctor for a much wider range of issues, much less severe symptoms. So that's one reason why maybe women come to be evaluated for MCAS more than men. That having been said, there's another factor that I think is much more important here, and that is the fact that women put out a whole lot more estrogen than men do. And it turns out that among the 300 plus receptors you got on the surface of the mast cell, there happen to be receptors for all the major sex hormones, estrogen, progesterone, testosterone. And when a molecule of progesterone or testosterone comes to bind with a progesterone or testosterone receptor on the surface of a mast cell, it actually inhibits the activation of the mast cell. But when a molecule of estrogen comes to dock with an estrogen receptor on the surface of a mast cell, it further activates the mast cell. And so why, once you know that, why would you be surprised at that point to see so much worsening of symptoms that are quite consistent with mast cell activation, see acute worsening of those symptoms in cycle with the menstrual cycle, in sync with menstrual rises in estrogen levels, and similarly in pregnancy. Oh my goodness, the worsening of the mast cell activation symptoms we see in many of these women who get pregnant and they don't yet have decent control of the mast cells. That's the whole issue. If you go into pregnant, if you have MCAS, you go into pregnancy, you've already got control over the mast cells. You're going to go through pregnancy pretty much as well as anybody who doesn't have MCAS. But if you don't yet recognize you got MCAS and you go into pregnancy and you get these massively soaring estrogen levels, then, oh yeah, can that drive a whole lot of troubles.
I wanted to jump in because there's actually some really interesting studies coming out from the long COVID area in sex differences, and some work that's being done at my institution by Sabra Klein, who's an immunologist dedicated to sex differences. So in the long COVID population, they found lower levels of testosterone in both men and women correlated with higher burden of symptoms overall. And there's a vast literature in the immunology world of the impact of sex hormones, like Dr. Afrin was saying. So they're basically testosterone in men acts to decrease the immune response. So that's why guys get the man flu and women don't, because the initial response to an acute infection is more robust in a female. But at the same time, that predisposes females to have higher activation of antibody-producing cells and dysregulation of the cells, which then results in the higher preponderance, perhaps, of women with autoimmune issues, long COVID, etc. So actually, I just proposed an ARPA grant based on the HHS that to test testosterone in females, very low dose testosterone, to as a potential intervention that could help that dysregulation in our immune system and flip, to favor a less inflammatory response. So
there are many women who, when they hit puberty, menarche, and they suddenly see a worsening of their mast cell activation symptoms, severe dysmenorrhea, menorrhagia, and their pediatrician or gynecologist, tries to help by putting them on an oral contraceptive. But in many of these young women, most of the oral contraceptives are a combination of an estrogen type drug together with a progesterone type drug. And so when you're loading more progesterone into these young women's bodies, it's no surprise that quite a number of these people will actually be made worse by these drugs. But then when you switch them from a combination contraceptive to a low dose progesterone only contraceptive, oh, then they get better with that, because you're not stimulating them with the estrogen anymore. And in fact, you're giving them more of a molecule that actually can inhibit mast cell activation.
Yeah, sweet. Thank you. I had one small question I wanted to add on to what Dr. Alba was talking about. So as she was talking about chromogranin A and serum tryptase being quite high, it was let me find the number here. It was 600 for the chromogranin A and 31.7 for the tryptase. So when do you start to think about neuroendocrine tumors?
Yeah, well, first of all, I try to trust my clinical instincts, and if I'm getting any sense clinically that there might be a malignancy there, then you better believe I go looking for it. But if there's no sense of malignancy and all I got to go on is the chromogranin level, if I've got a pretty obvious case of MCAS, if I got a proven case of MCAS, a chromogranin of 600 doesn't bother me at all. Buried somewhere in those slides, I don't think I had time to go through it, but I basically said if you've got it's common to see elevations in chromogranin in these patients up to roughly an order of magnitude above the upper limit of normal. If you see elevations beyond an order of magnitude, you need to start doing some more thinking about a neuroendocrine tumor. Now, in all fairness, I have seen at least a few MCAS patients where the chromogranin elevation was, 20-fold the upper limit of normal, and it turned out to just be the MCAS that was doing it, not a neuroendocrine tumor. But beyond an order of magnitude, you got to go think about if it's below an order of if the increase is below an order of magnitude. Honestly, that's not typically the way that an untreated an untreated chromogranin A producing neuroendocrine tumor behaves. An untreated chromogranin A an untreated chromogranin A producing neuroendocrine tumor is going to produce massive elevations in chromogranin A, well in excess of an order of magnitude above the upper limit of normal.
Okay, but they be generally recognizable by like a paraneoplastic syndrome or by like a carcinoid syndrome?
Yeah, you have to use your clinical, training and instincts to. Listen, it's an opportunity here to discuss an important point here. There's no question that MCAS can drive a million symptoms. 1,200 mediators, each one of which has a huge range of effects on the body. Yes, MCAS can drive a million symptoms. And unquestionably, once somebody has been definitively diagnosed to have MCAS, everybody can understand the temptation, the severe temptation on the parts of not only the patient, but all of the doctors treating the patient, that anytime a new problem emerges in that patient, to just go reflexively attributing that problem to the mast cell disease. Oh, the damn mast cells are just acting up in some funky new way. Well, let's just go reflexively start throwing more mast cell targeted treatment at it. But look, just because somebody has MCAS doesn't make it impossible for them to develop other problems. And yes, sometimes the other problems might be consequential to the mast cell disease, but it's also possible for the other problems to arise entirely independently of the mast cell disease. And you also know well that the window of opportunity for effectively addressing at least some medical problems is pretty short. And so anytime I explicitly teach all my newly diagnosed patients that anytime a new problem arises in them, the stupidest thing they could possibly do. I mean, I'm blunt with them about this. I said the stupidest thing you could possibly do would be to go assuming that the new problem is due to your mast cell disease and just start throwing more mast cell stuff at it. No, you have got to go get the new problem evaluated in whatever fashion happens to be appropriate for that problem, and in as timely a fashion as is appropriate for that problem. Obviously, different problems have different levels of urgency to them, and it does not matter one bit whether the doctor you're going to see for evaluation of that new problem knows anything about mast cell disease or not, because what that doctor does know is every other known cause for that problem. So you let him do his job. And if he happens to find that you really do have, let's just call it a traditional diagnosis that well accounts for that new problem, then congratulations, you've got a new diagnosis regardless of whether it's ultimately attributable to the mast cell disease or not. And the treatments which must be tried first for that new diagnosis are the standard traditional treatments, well established to usually be effective for that diagnosis. It's only if you went through an appropriate evaluation for the new diagnosis, for the new problem, and you could not identify a traditional diagnosis that well accounted for the new problem, or maybe you did establish a traditional diagnosis, but you tried the traditional treatments and they did not work, then you've earned the right to attribute the problem, or at least potentially attribute the problem, to the mast cell disease and to go start trying other mast cell targeted treatments. But listen, I have seen more patients than I care to count who, even after I've given them this explicit talk, they don't exercise the necessary self-discipline, and a new problem pops up and they don't take it, they just assume it's due to their mast cell disease, and they just start throwing more Benadryl or whatever at it, and they miss the window of opportunity to most effectively treat it. And I've seen patients who have been seriously, permanently injured as a result of that poor decision making, and I have seen patients who have died because of that poor decision making. So gotta be careful. There's a huge temptation to blame everything on the mast cell disease, but it's the wrong way to play the game.
I was going to
Yeah.
say that you better believe I looked for that neuroendocrine tumor on that patient everywhere and had
I'll be
multiple
the
people check it out.
I'll be the
That's
first
it.
to acknowledge that any new problem arising in a mast cell patient most likely will be attributable directly or indirectly to the mast cell disease, but that doesn't prove it. And it'd be silly to lose your life because you missed a narrow window of opportunity to get effective treatment for some new problem that in truth had nothing to do with the mast cell disease.
I'm going to jump in with a very quick question, but it's burning my soul. I have a patient that was recently diagnosed with hypersensitivity pneumonitis. I see you smiling because I know you have the answer for me. With a tryptase of 20 and then repeated 22.
Fine. Go run the gene by gene testing, see if they've got HAT. And if it's persistently greater than 20, you probably have to go do a bone marrow biopsy too to look for mastocytosis, but it's probably not going to be positive. And you're going to have to go look for MCAS. Look, I didn't show it in this talk, but I think I briefly put up a couple of slides at the very end of the first talk a couple weeks ago. This list that I've been accumulating over the last 16 years of all the diseases, all the diagnoses I've seen across my thousands of mast cell patients, where circumstances have been such that I think I think I'm not unreasonable for suspecting that some significant proportion of the patients who bear this diagnosis, that diagnosis, the other diagnosis, that what's actually at the root of the problem in a significant proportion of the patients with one or another of those diagnoses actually is some variant or another of MCAS. And you better believe that hypersensitivity pneumonitis is on that list, which now is in excess of 250 diagnoses, many of which, of course, are chronic, idiopathic, multi-system inflammatory disorders.
Oh, that makes my day. Thank you.
Now, all of that I just said, does it prove that your patient has a mast cell disorder? No. Maybe your patient has hypersensitivity pneumonitis due to something that has nothing to do with the mast cells, and maybe the tryptase is elevated because he's got a couple of extra copies of TPS-AV1 that itself really is not causing any issue at all other than jacking up the tryptase a little bit. So it's not proof that it's a mast cell disorder. If you want proof, go test for it and find the proof.
Right.
All
I'm
right,
going to ask
so,
the pathologist to look at the tissue. We had a biopsy, yeah.
so we have oh yeah, all right. So we have several questions coming in asking about hormones and menopause and things. So I'm going to bring up one of our attendees to talk about that. So EG, you are now able to talk to ask your questions because there's several in that same category. And if they don't want to speak,
if EG is trying to speak, her microphone is still muted. She needs to unmute. There you go.
Can you hear me?
Yep.
Okay, so my question is, when it comes to being in the early 40s, do you get an estrogen progesterone combination to deal with very severe symptoms of fluctuating estrogen due to perimenopause? And I just wondered if how that may impact like what you were saying about hormones, like if you have MCAS and you're not aware of it.
Yeah. Well, again, there's some non-trivial chance that the extra estrogen in that sort of a product might actually worsen some of your mast cell driven symptoms. And in that case, you got options. For example, you could try switching to a progesterone only contraceptive. You could try, there are a couple of classes of drugs that can interfere with the estrogen axis. There are estrogen receptor blockers. They're not called that. They're called selective estrogen response modulators, SERMs, SERMs, like clomiphene and tamoxifen and raloxifene and toremifene. Some of them are used for fertility purposes. Some of them are used to try to reduce the chances of relapse of breast cancer. But the bottom line is they all block the estrogen receptor. And I've had some MCAS patients who, when they take sometimes ridiculously low doses of one or another of these SERMs, they see remarkable improvement in some of their MCAS symptoms. There's another class of drugs too, the estrogen synthesis inhibitors. Yeah, they're not actually called that. They're called aromatase inhibitors. But what they do is to inhibit the synthesis of estrogen and actually some other hormones too. Drugs like letrozole and anastrozole and exemestane. These drugs, again, for the most part, they're used to try to reduce the risk of relapse of breast cancer. But fundamentally, if you're reducing the production of estrogen, uh, then who would be surprised if a disease that is sensitive to how much estrogen is floating around in you, who would be surprised if that disease gets a little better if you ratchet down your body's production of estrogen? You got to be careful, obviously we know from large studies that if you are too exuberant about it, torpedo estrogen production. That can have a whole lot of negative downstream consequences, bone health and other issues. But nevertheless, there are these other avenues that can be tried if estrogen really seems to be a problem for a woman's dysfunctional mast cells.
Thank you very much. Given the length of time we've been here, I'm kind of thinking we might we're going to keep getting questions piling in, I'm sure, and we could be here like for days. So we've got just a couple more we're going to go through. I'm going to be kind of hitting some of the attendees that are that I can bring up, and then I think we have one or two more questions from our panelists. So so the person I'm going to be bringing up next is will be Bree or Bree Ruthoff. If you should be able to speak now. As soon as you're ready, go ahead.
I'm sorry. I've got some speech to sound thing that goes on in the background that talks over. If you could read those for me until I figure out how to undo that, that would be great.
Sure, I'll read them off for you. I'll just kind of go through them, and then Dr. Afrin can answer as we go, and you can always stop me anytime. So that's kind of like three-part questions here for what Bree has. When genetics are done on mast cells, must one capture and sequence an abnormal mast cell? Can there be sampling error? Can MCAS cause erythromelalgia, red hot limbs, feeling like they're burning, etc.? And how can large treatment trials overcome the inherent heterogeneity? What's not coming up? MCAS. Is there a subpopulation that may respond to different number of treatments or something to be able to reach better research endpoints?
The heterogeneity issue is a very important issue, and I've been saying for many years that trying to do clinical trials in looking for efficacy of one drug or another in a general population of MCAS patients is probably not going to be a great way to go about doing this because of that heterogeneity issue. It's probably going to be better to go coning down to specific subpopulations of MCAS patients, however you might go about defining that. Maybe you'd find a population of, I don't know, hypermobile EDS MCAS patients, or a bunch of POTS MCAS patients, so on and so forth, fibromyalgia, MCAS patients, and then see what a given drug might do in that subpopulation. It is a significant issue. Melalgia, yes, definitely MCAS can drive that. It's not a terribly common problem, but I wouldn't say it's a rare problem either. And the first question, man, what's the first part of it again?
When genetics are done on mast cells, must one capture and sequence abnormal mast cells?
No, you don't have to worry about that. The dysfunctional mast cells are kind of all over the place in the body, just like the normal mast cells are. So whatever sampling you do, you're going to get some of both. So that's usually not an issue.
Okay, and then a next question that we have from one of our panelists. Let me pull it back up because he's not able to speak right now. So can you speak a little on, what is it, Bascule, B-A-S-Q or B-A-S-C-U-L-E syndrome? What could be causing it? This is a mixture of beer anemic spots and acrocyanosis, and also the role of small fiber neuropathy in MCAS. Is that upstream or downstream?
Small fiber neuropathy, again, nobody's done any studies to look at this, but in my experience, small fiber neuropathy almost certainly is just another consequence of, certain variants of MCAS. Again, where are these mast cells? They're in all the environment. They're dominantly at the environmental interfaces and directly abutting all vessels and all neurons. And who would be surprised if a bunch of dysfunctional mast cells that are directly abutting certain neurons and these mast cells go inappropriately dumping large amounts of their potent inflammatory mediators into the extracellular space. Those mediators are going to directly hit on the adjacent neurons. Nobody's going to be surprised if there's going to be neuronal injury from that, sometimes acute, sometimes permanent. And as far as the first part of that question, you said vascular syndrome?
Bascule, B-A-S-C-U-L-E.
I have never heard of that before, but I'm looking it up right now.
We
Well,
all do that exact same
right
thing.
off the bat, it's indicating that there are these issues of, pallor and cyanosis. So it's basically, hypoperfusion together with urticaria. So yes, it could easily be the case that some proportion, maybe I should go adding Bascule syndrome to my long list of diseases that MCAS might underlie. It's easily possible that some proportion of the patients who have Bascule syndrome might actually have some variant of MCAS underlying it. What proportion? Is it low? Is it high? I have no idea. The research has got to be done. Take a population of 20 or 30 Bascule syndrome patients. Take a sample of 20 or 30 hypersensitivity pneumonitis patients, 20 or 30 POTS patients or hypermobile EDS patients, and then do the diagnostic workup in that random cohort of patients bearing this, that, or the other disease that might be driven by MCAS. And then you'll see from the testing, and you'll publish a paper that'll say it's this percentage of the population of patients with Bascule syndrome who appear to have a definable MCAS in them. And if you get a percentage that is more than, say 5 or 10%, and given that in all the years of studying Bascule syndrome and POTS and hypersensitivity pneumonitis and HEDS and so forth, nobody has ever been able to figure out any cause for those patients. Well, if you find that even 10 or 20% of the patients with one or another of those diagnoses has a detectable, a definable, a provable MCAS in them, then, oh boy, that really is interesting. And at that point, you should start doing larger confirmatory studies, and then you should look for exactly which mast cell mediators are driving the clinically apparent phenomena in that more superficial diagnosis. And then you should be looking at which particular mutations are shared in the mast cell regulatory genes in the patients who have a bascule syndrome underpinned by MCAS or a hypermobile EDS that's underpinned by MCAS, so on and so forth.
All right. Thanks. Thank you. And then Ellie has a question for you. So Ellie, whenever you're ready.
It's actually two questions. I take heparin shots, and a number of other people do take the low molecular weight heparin shots. And it's curious to me because you look for high heparin, but some of us are taking heparin. Is it helpful maybe because if the body is sensing that there's more heparin, that it doesn't have to degranulate more mast cells to get heparin? Or is this only going to work in people who have the hypercoagulation tendency? And then my second question is, do you keep track of all your patients' triggers so you can see which triggers are the most popular?
I mean, I try to guide my patients, teach them to, re-examine the circumstances surrounding them anytime they've had a flare of any of their symptoms, so that hopefully they can, come to better pin down over time which particular triggers are setting off different types of flares in them. And as they come to report to me having clearly identified one particular trigger or another, yeah, I document that in their chart. Many of these things I add to their allergy list. As for heparin, again, I have seen a few patients who have gotten started on heparin treatment for various reasons related to, use excess clotting. And we actually do find some improvement in some mast cell activation symptoms in them. I haven't figured out yet the mechanism, but I mean, obviously the heparin has got to be coming to engage with the mast cells either directly or indirectly to bring about those effects. I haven't figured out yet exactly what that mechanism is, but I'll tell you too, I've also seen patients who have gotten one heparin product and another, and oh my God, do they have a bad acute reaction to it. And usually in that case, it's actually not the heparin that's doing it. If you investigate it carefully, listen, it's common for mast cell patients. We'll talk more about this next weekend, but it's common for these patients to have adverse reactions to medication products they're newly trying. But when that happens, it's almost never the drug that's actually causing the problem. It's almost always some excipient, some filler, binder, dye, preservative that's mixed with the drug. That's what's usually triggering the dysfunctional mast cells to further activate and spew out all their mediators, which are what's actually driving all the symptoms in that reaction. So any time a mast cell patient is trying a new medication product and pretty quickly starts having an adverse reaction, you don't give up on the drug. You just give up on the formulation of the drug that was causing that problem. And you look at the ingredient list, you try to figure out which excipient was likely the troublemaking trigger of that reaction. And then you work with the pharmacist to try to find an alternative formulation of the same drug, same dose, whether commercially available or compounded, but you try a different formulation of the same drug that just does not contain the suspected offending excipient. And most of the time when patients do that, then they have a completely different experience with the alternative product. And since the drug is exactly the same, it's not the drug that caused the problem, it was the excipient. And at that point, it's the excipient you put on your allergy list, not the drug.
Is gluten a high percentage of your patients having as a trigger?
I see a lot of patients. It's a non-trivial proportion of these patients who have a gluten sensitivity. Far fewer of them actually meet diagnostic criteria for celiac disease, but there's a good number of them who are gluten sensitive. I wouldn't say it's the majority of MCAS patients, but it's a non-trivial minority.
Thank you.
I cannot believe that 30 people have hung in here for 3.25 hours. I'm impressed with all of you people.
Yeah, and while there's a mixture of clinicians in there, there's also a mixture of chronically ill folks too. So they're really
Either
uh,
way,
so yeah, that's pretty impressive for them for both clinicians who have to have very have to really privilege their time, and then
thank
also
God we're
us
doing it
chronically
on a
ill folks.
Saturday, you know?
Yeah. So Alba, it looks like you might have a question.
No, no,
No?
no.
No?
I thought we
Okay.
were saying goodbyes, so I just wanted
Oh,
to.
you're like, oh no, we're only gonna do a couple more just because I think by the next, I think 10 minutes and will be it. That because I think we're all gonna be kind of fried, and that's a nice round number. So but there's a question in the chat that is relevant to this too, and it's are you involved in the training of new generation of practitioners to take your research on like to the next level and for clinical experience on that? And then the person also wants to say, you are a leading light in the field, of course, but we wonder who, beyond the sorts of webinars and medical education work and that, will take up the mantle of your work in the years ahead. Not that we want you to retire anytime soon, but we want to make sure that this continues to live on.
Oh, there are plenty of other doctors who are coming to know this disease fairly well and beginning to pursue research in this area. I've been very privileged over the last 6+ years to have been able to assist in the development of a growing network of professionals around the world who have interests in this area. Nobody is essential. So whether I'm here or not, there'll be plenty of other folks to keep taking this forward. The first part of that, remind me again the first part.
Let me pull it back up. Are you involved in the training of the next
Yeah, the
generation of
training.
practitioners?
Look, I was actually at major academic medical centers for the majority of my career, and ultimately I left academia about 7 years ago. I was getting so frustrated with so many of my smart colleagues just persistently denying the existence of this or denying the prevalence of this, kept telling me it makes no sense you're finding so many cases of mastocytosis. No matter how much I told them it wasn't mastocytosis, they could not wrap their heads around this concept that there was this other mast cell disorder that just had a number of significant differences from mastocytosis. You get to a point where you're just fighting every day with your colleagues to get them the treatment you know your patients need from them, and it got to a point I just wasn't going to do it anymore. So I'm in a happier place now working with colleagues who actually do get it. And I'm not having battles every day to get my patients the types of care that I've learned they need. Not having my colleagues, my direct colleagues, actively deny the diagnosis. But in terms of training, while I was in academia, I was routinely lecturing in this. I have been routinely lecturing even since I left academia. If I'm happy to teach, I'm happy to share what I've come to learn about this disease with any other professionals who want to learn about this. I've never asked for an honorarium in this. All I ask is for, routine travel expenses to be covered if travel is involved. Many times, of course, we just do it video. And I've given lectures to all sorts of, academic forums all over the world, but a number of private forums like this one as well. While I was in academia, I actually was the fellowship program director for hematology oncology at these two institutions. And when I started coming to understand MCAS, I started trying to figure out how do you systematically teach the trainees about this. How do you teach them didactically in the classroom? It's such a heterogeneous disease, so variable in its behavior. How do you give a medical student an impression of what this looks like so that when they leave the classroom, they have a picture in their head of what one of these patients looks like? So if they see a patient like this in the clinic, they can actually have a prayer of recognizing that maybe it's MCAS, it's what's going on in the patient, and trying to figure out how to do that didactically is very, you can give a lecture like I did my MCAS 101 lecture, but the actual symptoms are so all over the place that you can understand how a student coming out of a lecture like that still going to have a pretty hard time clinically recognizing one of these patients. So even beyond the didactic education, there's the clinical education. How do you teach a clinician in training, a resident, a fellow, how to recognize this? And basically, it's a matter of just exposing them to it in the context of some more senior clinician who actually has familiarity with it. Because I'll tell you this, not only in the years I was in academia, but ever since too, I have residents, fellows, students. Sometimes I have other attendings who come to my clinic for a day or two, three, a week, whatever, and just sit in the corner and observe as I come to, take a history, do an exam on a new consultation for suspected MCAS, or I see, some follow-up patients, and they come out of that 1-2 day experience and they say, oh my God, I've been seeing these patients all day long, every day, left and right. I just couldn't previously recognize them for what they have. But now that I can recognize them, because I see the overarching pattern, I see the meta patterns to this, and I can go run the diagnostic workup because there is a diagnostic workup for it. And then once we have a diagnosis, I can treat them. There are treatments for this. And I've been very privileged the last 15 years to have a number of these doctors who've gotten this clinical education. They take their valuable time, 1, 2, 3 years down the road from their light bulb moment, and they call me up and they say it's just been so delightful to see these poor people who've been chronically, mysteriously, multi-systemically unwell for 5, 10, 20, 50 years. And everybody had long since thought they were psychosomatic or equivalent, and they were just dismissed. And no, they're not just anxious or psychosomatic. They got a real problem. They know exactly how they're feeling. They're not imagining it. And we run the diagnostic workup, we prove it, we treat them. And in that respect, it's like any other disease. You give the right treatment for the right diagnosis, the patient gets better. And these doctors, after learning about this, they follow up with me and they say, it's just such an enjoyable thing to see these poor patients finally getting better. Sometimes even it's just the diagnosis that is an immense source of relief to them. They're not imagining it. It's not in their head. There's a real provable biological problem in them. And then you find one treatment or another that actually gets them better. And many of these people, they've been completely disabled for a long time. And then you give them the right treatment and they're back to work. I've had I've had patients who've been completely disabled for years. I put them back in the cockpit. I've had a patient who, she's made a public story out of her course with the disease. She had been completely disabled, and within, I don't know, a year or two of getting better, she decided to take up ice skating, figure skating, and in her first year of doing it, she became the amateur champion for her state in figure skating. Many doctors have told me, and I think it's a reasonable description, that when you come to know this disease and you start seeing the benefits from treating it, it's like chicken soup for the doctor's soul. Many doctors, for very understandable reasons, they are so close to burnout, if not already past the point of burnout. But when you can see, and again, it'd be one thing if this were a rare disease, if you rarely got one of these patients better, but that's not the case. This is a prevalent disease, just almost entirely unrecognized at present. This is the 800,000-pound invisible elephant in medicine's waiting room. And once we come to recognize it and diagnose it and treat it, we're going to find an awful lot of people getting better that we previously had written off forever.
Yeah, it's so prevalent that they see it all the time, so therefore they don't see it. So it just ends up being kind of ignored that way. But
well, they don't even know it exists. You know, they haven't been taught.
So, well, thank you so much. We love your passion, and we love how patient you are with both us and all of your patients and the research. We always enjoy clinicians that are very excited to help their patients, because some of us have not always gotten that. So again, we thank you so much. We look forward to seeing you next week. And for the participants who have still hung on here, we will make sure that you guys have a copy of Dr. Afrin's slides, and then also that website that both he and Ellie were talking about. We'll make sure that's also in there too, so that way in a follow-up email after this, so that way you guys will see you again next week. So again, thank you so much. Unless anybody else has any closing remarks.
Thank you for
right.
having me
Thanks
as
for
a
the
first-time
opportunity.
panelist.
See
Yeah.
you next Saturday.
All right. Well, thank you so much, and have a great rest of your day, whatever that might be. Hopefully everybody gets a chance to relax after this very long session.
All right. Thank you. Bye.
Bye.